Professor
Good
Abdus
morning,
Samet.
Professor.
Welcome.
Hi, Mehmet. How are you?
Yeah, it is great pleasure to be with you.
Thank you very much for invitation.
Are you, Yoko, are you in Sofia now?
No, I cannot because of
You
the some
couldn't go?
yeah, because some university some issue, so I cannot.
Okay, okay.
Yes,
You
sorry.
have said this before, yeah.
Yeah.
Good
Are
to
you
see
in
you.
Sofia?
No, I'm in Izmir. No, I'm
Izmir.
not.
Okay. So Sabino, how are you?
Professor, nice to meet you. It's my best pleasure. It's an honor for me. It's an honor for me to speak, after you, and you are a giant and I'm a plankton in the sea today. So it's a real I'm feeling anxious today. It's one of the, more complex day. Anyway, everything okay.
Yes.
Thank you so much.
Yes.
I have not enough word to say thank you once again to Professor Zileli and World Federation.
Yes, Mehmet, thanks
It's
so much.
our pleasure, Sabino. Abdus Samet,
Professor.
welcome.
Hi.
How are you, Mehmet? How are you doing?
Hi,
Good
Hobby.
to see
How are
you all.
you?
Hi,
Hi, how are you? Hi,
Good.
how are you? Fine,
Good.
thanks. Fine, thanks. Yes.
Nice to see you
Yes.
again on by
Yes.
Zoom.
Yes, you looks very nice.
Yeah. Well, it's 10 p.m. in Japan.
Yes, Japan is 10 p.m. now.
Okay.
So Morocco is
2 p.m. It's
2 p.m. Okay, it's a good
yeah.
time. Good time.
Yeah.
Saturday, yes.
Nice to meet you.
Very
So,
nice to see
Lily,
you.
how are you? With this,
Welcome, Abdus Samet.
thank you for what doing for this webinars, and you are keep continuing really very, very active. One after one.
We are trying with your help.
No, that's good.
It's a pleasure to be with you.
Perfect.
So, Irab is from US. Maybe he will be the last speaker. So still, we don't see his face.
Nirav did not join yet, but I think he has promised he will be here.
Oh, okay.
As you know, he's a interventional guy. Nirav is with us now.
Okay. Hi, Nirav. How are you?
You must unmute yourself, Nirav.
Hello.
Nirav.
Hi, welcome.
Nirav, my friend.
Hi, Sabino.
Everything
Hi.
okay?
Professors, good to see you all.
Yeah.
Working on Saturday working for you. We see.
Yeah, we have a stroke thrombectomy case to do.
Oh, okay.
How are you all doing? It's nice to be here.
Thank you.
Good to see you all. Yeah.
So patient is well after thrombectomy.
They're about to be here, coming in about 30 minutes, stroke case. You know, they come always middle of the night, middle of the day. It's a constant stream. But luckily we have good fellows.
So usually the door to reperfusion, how much?
From the door to reperfusion is it has to be under 60 minutes.
60.
Yeah.
It's very ideal, I think.
Yeah.
At least less than 90 minutes, I think.
Yeah. But now, the truth is we're getting more, and the indication for thrombectomy is growing. We don't turn anybody down. 2 years ago, if there was a holohemispheric infarct, you don't do the case. Low aspects, 3 or 4, you don't do the case. But now, even large core infarcts are being thrombectomized because the studies show a benefit.
Okay.
The reason is that the complication rate is so low. That's the main, and the natural history is so poor.
Okay. They became a better.
Yeah, we just better equipment, better technique. Yeah. Yeah.
So usually in our institute we skip the mRNA.
Yeah.
Only 3D CTA. and go to
Yeah,
the angio
that's
suite.
right. That's right. Yeah.
Angio
That's
suite.
right. That's right. Yeah. Very few MRs. We don't do MRI anymore, just straight to
Yes.
angio. In fact, like this
Yeah.
patient is coming from another hospital, Cape Cod,
Yeah.
and they're going to come directly to angio. They don't come through the CAT scanner. They already got the CAT scan at the other hospital,
Okay.
straight to angio.
Good. Okay, great.
Saves time.
Thanks.
Edwin, welcome. You can unmute yourself.
Hello, sir. I'm very happy to see you.
Yeah, are you joining the Sofia meeting, EANS meeting?
I'm gonna be in Sofia. I'm gonna be there. Yes.
Yeah, okay, good. Good to see you. Welcome.
Yeah, thank you.
Oh, Vladimir is with us. Welcome, Vladimir.
Hi, Vladimir.
Good to
Hi.
see you.
Hi,
Good
how
to
are
see
you?
you.
I'm fine. I just want to listen today, which I love.
So, Vladimir, thank you very much for sending the book.
Oh, for nothing. That's all right. It's a pleasure, Yoko.
Yeah,
As always.
So wonderful, the book.
Very
Thanks so
good.
much.
Good company today, as I see.
I think it is 4 p.m. Here in Istanbul, and this is our. Shall we wait some more? What do you think?
Two.
This is today we will have two different education symposia. The first one will be the 10th symposia this year, and this is on the surgical management of complex intracranial aneurysms in endovascular era. My dear friend, Professor Abdesamet El-Huabi, will be the moderator. I will leave my place to Professor Abdesamet. Yes, Abdesamet.
Okay, thank you, Professor Zelili. Thank you for once again for the organizing of this webinar, and happy to be with you, all of you. It's really nice to discuss this subject. I will moderate this session, and I will ask my colleague just to give a presentation 15 minutes, so we will have time maybe to discuss. So the first speaker is Professor Yuko Kato. She will speak on management of anterior circulation aneurysm. Please.
You can share your screen, Yoko. You must unmute yourself.
Good.
Hi, hello everyone. Thank you very much for invitation this time. So especially to Dr. Mehmet, my good friend for many years. And thank you very much, the chair of the LHABI and my colleagues. So today, my talk, I was asked to talk about the management of anterior circulation aneurysm, but recently, most of the aneurysm is treated by endovascular. So I think maybe the Irab can talk later. His word, I think. So this is a little bit before the paper. If there is a role of the surgical clipping for cerebral aneurysm, such kind of the intracranial hemorrhage and also blister type aneurysm and the failed endovascular treatment. and also the treatment after coiled aneurysm. And sometimes we can offer the young age and good clinical grading. So, so many texts, maybe I can skip. Such kind of the large giant aneurysm or aneurysm with thrombus. And the challenge is the complex aneurysm anatomy. Once the aneurysm became larger, so we must think about the very precise anatomy and branches coming from the aneurysm itself. So this is not anterior circulation, but it is a posterior circulation, the giant, the partially thrombus, the aneurysm. So I used this video many times. So maybe the audience, some of the audience must be very young. So this is a large or giant aneurysm. It is quite difficult from the usual the aneurysm because the wall became very thick, and also the basal vessel is growing. We can see the very large totonate vessels. So that is one of the nutrition. That is our responsibility for giving the nutrition to the aneurysm. So that's why this case is so many times stent coil, but still growing. So for these cases, maybe one of the role for the open surgeon. So we cut the aneurysm wall, and so we find back coil. And when you extract of the coil, maybe you can cut the coil. It's easy to remove because a very simple procedure. So we move the coil until we can see the stent. So this is one of the role of the direct surgeon. And also the what is a good techniques? Of course, the clipping techniques, and also the bypass and the adjunct techniques, such as ICG or Doppler, and also the MEP, such kinds of the monitoring. And the preoperative planning is very, very important. So before we go to the operation theater, maybe we can reconstruct in your brain. So another important thing is how you can manage of the intraoperative rupture. Of course, so many techniques we must learn, and also the recently the intraoperative monitoring is very, very important, such as ICG or SSEP or MEP, so on. And once SH case, so maybe the prevention of the vasospasm is very, very important. So now in Japan, we use the Craniocervical, and it's very, the treatment of SH became very simple now. So early detection of the vasospasm or monitoring of the hydrocephalus for the rehabilitation and the long-term follow-up. So the best practice for avoiding the complication is through preoperative planning, and also the meticulous surgical technique and intraoperative monitoring, and also the collaboration with endovascular team. So as an open surgeon, so do it better than endovascular therapy. So the three principles, the minimally invasive surgery, such as a mini-terional or small craniotomy, so on, and also avoid recurrence after clipping, and also the bypass technique we should learn. So this is a flow chart of the procedure. So we always introduce of the endoscopic assistant, and also the before and post the clipping. So already I talked so many tips, but suction decompression is another very important issue, and also the adenosine sometimes you can use. You can calculate the time, how much you need to stop the bleeding, and also the clipping technique, so on. So the anatomy is another very important thing when we deal with IC, such kind of the PCOM aneurysm. So maybe I think as an endovascular treatment, maybe I think anterocoidal is quite difficult for endovascular team, I think, because most of the anterocoidal aneurysm is very small, and also the wide neck, and the height is very shallow, I think. Maybe and the big PCOM cases is maybe sometimes difficult for endovascular cases. So this is very simple anatomical things. When we remove the anterocranial process, we can reach the C3 proximal the IC. So here is a distal ring, and this is here is a proximal ring, and this is the cardiac membrane. Here is a cavernous sinus. So the clinoid process removal is one of the key techniques. So this is an indication for ACP removal, alkynoid aneurysm, or large or giant aneurysm of the ICA, or improving proximal control, or enhancing of the visualization, or facilitating temporary clipping or cavernous sinus involvement. The optic nerve decompression, improving the clip placement, the facilitating the complete aneurysm obliteration or intraoperative assessment. So this is a very basic things. How you can remove anterocranial the process. Usually our department, we do not use the drill because of the heat injury. So this is a special punch for removal of the anterocranial process. And the bleeding from the cavernous sinus, we can put some surgical or some glue. It's easy to be stopped. Then additional, we can remove of the bone with ultrasonic bone, the drill. So only this procedure, maybe you can reach, or you can have a mobilization of the intercardiac artery, or you can see the more proximal side of the aneurysm, and also the proximal IC control. So this is more how we can remove of the anterocranial process, and how you can make a plot of the skull base. Just a very small, the tiny drill opening. That is enough. Then we can see the proximal IC. If you need more space, just you can remove all the bone. So this is a very dangerous aneurysm because just it's a touch of the dura itself. You should be very careful. So this is ICG, of course, you know, and this is quite a small the aneurysm, but the wall is very thin. So this is the second clip. Complete occlusion of the aneurysm. So again, this is a very typical IC proximal aneurysm. Again, the same procedure. Then we can have a more space in the skull base. Now we can see the second nerve and IC Of course, and now that we can use the flow diverter, or sometimes according to the aneurysm shape, we can use a wear. So this is another case of the IC, proximal side. So for this for this case is we use a suction decompression as the trap of the IC, then shrinkage of the aneurysm, then during that time, so we can place the suitable clip on the aneurysm neck. So this is a very interesting video because this is a blister-like aneurysm. So it was a very terrible case. So many tips. Now you can see that this is a red one. We can see the pulsation. We are not sure where is the neck, where is the dome. So just to be during the observation of the aneurysm, suddenly it is ruptured. So the 1-point suction, then we can make a clear the surgical view is very important. That is an assistant role. So during that time, we put the temporary clip. So sometimes it's quite difficult to place the suitable aneurysm clip, just like a usual aneurysm. So we reinforce of the IC or aneurysm wall, then we can place the clip, including of the neovel reinforcement material. So this is a real blister-like aneurysm. So the challenge is the close proximal proximity of the anterior colloidal artery to the ICA makes a dissection and clipping delicate. So reconstruction technique is very important. So maybe we cannot see the inside the aneurysm, vessel wall. So just we can make a reconstruction of the apparent vessel a bit large. It's one of the tips. Otherwise, it makes some stenosis because we cannot see the inside of the aneurysm. So this is the potential point of the complication. So many things. And also the anatomy and the complex consideration, MCA bifurcation aneurysm. So many perforators. You should be very careful. And sometimes the large type of the aneurysm, we use a fenestrary clip. And so many important tips. So this is just showing the large type of the aneurysm. The ICG, already we can see the aneurysm. So this is the insurance bypass for a longer time of the ischemic duration. So once we confirm of the aneurysm, expose of the aneurysm, then how we can make a neck, aneurysm neck, that is one of the tips. We can treat such kind of the large type of the aneurysm. Another case is MCA. So again, the exposure is very important. So that we can dissect the cerebral fissure as much as possible. And we can place the temporary clip of the main branch. So we can make main trunk a bit bigger. That is a kind of tips. So this is a combination clipping. then if there is some space for additional clip, then we can add the clip, or if the color of the aneurysm has been changed. Okay. So this is another one. So this is a bigger one. Whole M1 is a neck. So, but I'm not sure because we make some the M1 trunk, but we are not sure because that part is healthy, the aneurysm, the wall, or still pathological parts. So this is the only way as an open surgeon. So just we need to be careful about the perforations. Then we can check the ICG and also the endoscope, and then we preserve all perforating arteries. So this is one last case is that this is a right M1 perforated thrombosed. So for this case, the perforated thrombosed part, the one branch is come from that part. So the white part is already the thrombosed part. So that we put the fibers, then we cut that branch. So after fibers, then we reconstruct of the so this is a I think one of the way. So this is the indication of the high flow fibers. So for this case, so we did the right side. We put the high flow fibers. Of course, now is maybe the endovascular treatment can be applied for this case. So after the insurance fibers, we use the saphenous vein for this time. Sometimes we need, then vascular surgeon must learn that we check with ICG and so this is high flow fibers. So one last case is this is ACOM aneurysm. So the combination clip, how we can put the clip, that is another issue for to be learned. So for this case, through the interhemispheric approach, so we divided the aneurysm into two parts. So the first, the clip, and this is the second one, and we use the 3 clips for complete occlusion of the aneurysm. So this is a very, very important things. So as a direct surgeon, we must learn the 3D simulation, ICG video angiography, endoscopic observation, or bypass technique. And this is an endovascular surgeon. And of course, that they need to know so many things, because recently, the day by day, so many devices is coming up. So then the hybrid neurosurgeon in Japan, most of the endovascular treatment done by neurosurgeons. So we almost younger neurosurgeon is a hybrid. So this is my talk. Thank you very much.
Thank you very much, Dr. Fatou. This is excellent presentation, and as you mentioned that we should practice good microsurgery to have this technique that will last and stay for many years, in addition, of course, the endovascular. Thank you very much. So maybe we can have some question at the end. So we should maybe go to the next speaker. Next speaker, Professor Sabino Luzzi from Italy, and he will speak about the management of posterior circulation aneurysm.
Can you hear me, Professor?
Yeah, perfect. Yeah.
Can you see my screen?
Sure, it's okay.
Okay,
Good.
thank you so much. Thank you so much once again. It is my best pleasure to be here today, and I have not enough words to say thank you to Professor Zileli and all the speakers and for this kind invitation, World Federation. It's an honor for me to be here to talking about my humble experience about the management of posterior circulation aneurysms. My first slide focus on the natural history of posterior circulation aneurysm, and this is what we know today about posterior circulation aneurysm, and the natural history of this aneurysm is particularly dismal, especially in terms of giant aneurysm, and we can see here has the 5-year cumulative risk of bleeding, especially for giant aneurysm reached 50%. So it means that half of the patient that we diagnose today will bleed. So there are no question about the fact that there is a clear indication for most of these posterior circulation aneurysms. And this is an overview that summarizes what are the main features of what we call today complex aneurysms. And if we take a look to the posterior circulation aneurysms, we see that most of them hold the same features that we, listen in the field of complex aneurysms. So practically speaking, it means that most of the posterior circulation aneurysms can be considered as complex aneurysms because of the architectural features and because of the narrowing corridors that we deal about, and also because of the atherosclerotic changes that usually occur at the level of most of these aneurysms. And this is an overview of the treatment option that we have today for intracranial aneurysms in terms of open surgery and in terms of also, coiling and the most recent pipeline and the flow disruptors, Web, Luna, and so on. And this is an overview of an article about our personal institutional experience. And here it is the series of my previous chief, Professor Galcio, about posterior circulation aneurysm, about critical appraisal. We titled with this article in a surgical series of in endovascular era. And we recently reviewed 20 years of his main experience with an average age of this patient. And 98 aneurysms were ruptured in this series, and 155 were surgically treated with a very long term follow-up. And if we see about the incidence, we saw that the most of them occur at the level of the quadrifurcation of the basilar tip. And then we have the V4 intradural segment of the vertebral artery, and then VBJ and proximal pike, and then mid-basilar trunk that fortunately are the most challenging one, but are also the most rarest one. And if we take a look to the distal aneurysms prevalence, and these distal aneurysms are very important because they are suitable for surgery in most of the cases today. In our series, the most frequent were the posterior cerebral artery, and then the pica, and then the ICA, and then the SCA that are important also. And this is an overview of the technique that we use in treating this kind of aneurysm in terms of posterior circulation aneurysm. This is an overview, and in most of the cases, they are suitable for clipping and clip reconstruction of as a technique, and these are the main overall results of surgery when we talk about posterior circulation aneurysms that are totally, you know, offer an overview of the results of surgery. Okay, this is our only personal institutional experience, but these numbers are in line with what we found in the literature, and most of these aneurysms are, you know, treatable with surgery with the modified ranking scale ranging between 0 and 2. That means an overall very good outcome. We also focus on the pica series, and pica still today is one of the most important and suitable aneurysms for surgery. And we recently reviewed, you know, our 10 years experience with 25 aneurysms surgically treated, but all of them with very long, very good, you know, follow-up. And here we can see when we look at the pica series that the segment prevalence, what was toward the most was toward the higher incidence in the proximal, so-called proximal aneurysm that you know, are vertebral artery pica, proximal pica, anterior and lateral medullary segment of the pica also. And also for this kind of aneurysm, in most of the cases, they are suitable for surgical clip ligation and rarely with pica to pica in situ bypass. This is a small aneurysm, but this is proximal aneurysm. This is incidental. This is, you know, not suitable for calling, in my opinion, because it is very close to the takeoff of the pica, vertebral artery pica aneurysm. So it's better to treat this aneurysm with surgery, and this is the results. And this is another one that is very distal. We perform here a paramedian suboccipital approach, 1 year of surgery, and you can totally exclude aneurysm here, despite it, and no way, at least in my humble opinion, about the fact that, you know, these are very, you know, treatable with surgery and with very good results. And this is one of the articles that I published when I was very, very young. This is one of my first, and we described an extracranial aneurysm of the posterior inferior cerebellar artery. They are very rare, but there is a red flag for this kind of aneurysm because there is the need to perform the 4 vessels digital subtraction angiography. We need the bilateral vertebral artery injection because otherwise we risk to miss this kind of aneurysm, both them that are considered extracranial and extradural. This is the overview of the outcome in terms of total and especially durable exclusion rate of these aneurysms. And once again, most of them consider that this series is most serious with most ruptured aneurysms with hematoma. But despite this, in most of them, more than half, they have very, very good outcome with surgery. So it means that nowadays we have enough data in the literature and also in our humble experience to justify microneurosurgery and to sustain the role, the critical role that microneurosurgery still have in the treatment of posterior circulation aneurysms. I want to take a look, and I want to focus just for young neurosurgery about some technical aspect. Neurosurgery was born with the transcisternal approach. Recent modern microneurosurgery was born with Professor Yashargi and transcisternal approach, and he gives born to the microneurosurgical area. Why? Because he taught us to navigate the system to reach the different part. And another important aspect is the planning of this aneurysm. It's very important, CT angio, 3D CT angio, but it's mandatory to perform also in most of them MRI, especially in the thrombosed one. If we planned to perform a bypass, it's super important to perform 6 vessel digital subtraction angiography involving also the injection of the superficial temporal artery and occipital artery, especially in terms of posterior circulation aneurysm. And today, there are no doubt about the critical role of baseline you know, about the neuromonitoring during surgery, especially brainstem auditory evoked potential. We use a very, very huge, you know, landscape of positions, semi-sitting, prone, supine, whatever you want, and the Concord, 3/4 prone. It depends by the approach that you want to perform, and it depends also by the preference of surgeon, but the basic principle of positioning of the patient are the same. You have to be, you know, sure to allow for a very good outflow from the cranial district, and we have to know when we approach this aneurysm beautifully the anatomy in terms of not only normal neurovascular anatomy, but especially for variation, because we have lots of variation, especially at the level of the posterior circulation aneurysm, especially at the level of the pica. The pica is the most important, most variable artery inside the brain. And we also have to know, some feature about the variants. And here, for example, this is a super high riding basilar tip aneurysm that we have to know before to choose the right approach. This is an overview of the factor that I personally consider when I plan approach for a posterior circulation aneurysm. In my opinion, three main aspects should be taken into account. The first one is the need for exposure to the aneurysm. The second one is the proximal control that we want to have to the aneurysm, and the second one to the parental vessel. And the third one is the strategy. For sure, is totally different if we plan a bypass or trapping on the clip reconstruction of the aneurysm and so on. So this is an overview, especially for young neurosurgery, about the transcranial approaches that we usually can perform for anterior, but also especially posterior circulation aneurysm. And we see here the amount of the exposure in terms of clival and related area when we approach this kind of aneurysm. And this is an overview of all the approaches that we routinely use for posterior circulation aneurysm. And as we will see very soon, pterional and COZ approach that are anterolateral approach have a critical role, especially in basilar tip quadrifurcation and basilar tip aneurysm. And this is what we have and what we can do to expose this kind of aneurysm. Focusing on basilar quadrifurcation aneurysm, depending by the preference of the surgeon and the riding of the aneurysm, we can use these three kinds of, approaches: pterional COZ, anterolateral approach, subtemporal transtentorial, the classical Drake approach, and today some authors also suggest the use of subtemporal transpetrosal approaches, the so-called Kawase approach. And we have to take account also that we have lots of variation in terms of anterolateral approach that allows for variation in terms of bony exposure, but also corridors, intradural corridors exposure. And we can tailor some of this approach to treat basilar quadrifurcation aneurysm also. And in this recent article, I review what are the tips and tricks to tailor the approach in this kind of aneurysm also in terms of superior circulation. This is an overview of the intradural corridor that we can use for basilar quadrifurcation, basically transsylvian, subfrontal, pretemporal, subtemporal, also in so-called half and half. And also in this, critical, there is a critical role of optopterional, especially COZ approach, cranio-orbitozygomatic approach. This is an article that I recently published about how to tailor this approach. And in this article, it is very well described that the zygomatic arch is the key to fully expose the basilar quadrifurcation. As I will show here, this is just a draw to show you how can increase how the angular exposure to the target, and the target here is the basilar tip, can be increased. Here we have the basilar tip aneurysm with the brainstem, and also we have the zygomatic arch. And what we do here is the critical exposure in terms of, interpeduncular fossa here going through the zygomatic arch, because the amount of increase in terms of angular exposure has been estimated to reach the 50%. And also we have pterional pretemporal transcavernous that can be used for normal riding and low riding aneurysm, COZ that can be, as already told, beautiful use for so-called high riding aneurysm. And this is an overview of the intradural corridor, especially to the P1 proximal segment and the interpeduncular fossa about and in doing this, we use some deep windows, the so-called deep windows between, for example, carotid oculomotor, oculomotor tentorial, and so on. And most of them are related to the transsylvian perspective, and other of them are related to pretemporal, subtemporal, like COZ approach. And this is a case, for example, of basilar tip aneurysm that was here. Three different corridors were used, 1, 2, and 3, opticocarotid, carotid oculomotor, and supracarotid corridor to treat this complex aneurysm. And don't forget the role. This is a case of, of my mentor, Professor Galzio, that was a master in terms of he popularized the so-called endoscope-assisted technique, and this is endoscopic assistance of the posterior circulation, the SCA aneurysm. With this technique is beautiful to spare, here thalamo-perforating artery in this area for these aneurysms that are very challenging. And also, this is a pre-op and post-op, and this is an overview of, anterolateral approaches that they role for posterior circulation aneurysm. We see that up to 23% of aneurysms in our series were treated with the so-called extended pterional approach. That means maximize the exposure in terms of drilling of the lateral sphenoid wing. Mid-basilar trunk and vertebro-basilar junction. Today, there are very few indications for this kind of aneurysm. For sure, these aneurysms are 99% suitable for endovascular treatment, but just to know that exposure of these aneurysms can be done with combined petrosal approach, but we have a role still for surgery, critical role for proximal pike and vertebral artery. As I showed you in our personal series, they were the most frequent. And far lateral and the extreme lateral approach are beautiful approach for this proximal pike aneurysm. And this is a case of giant vertebral artery pike aneurysm that was treated with clip reconstruction, totally sparing the takeoff of the pica here, and the patient went so well, and this is a pre-op and post-op. And this is the final result without condylectomy here, because a transcondylar fossa approach especially was performed, sparing the condyle. And this is an overview, once again, of the approaches that we can use, especially to approach the vertebro-basilar junction system, so the lower third of the posterior circulation here. And this is the exposure of the pica and the proximal anterior and lateral medullary segment of the pica. These are the key steps of our lateral approach. Just a trick, don't forget to put the patient in this position, because this is, the tip of the patient should point to the floor, because this is basically an infrajugular tubercle approach. And don't forget, and also during the skeletonization of the vertebral artery, up to 25% of vertebral artery pica can take off from the vertebral artery in its V3 part. And this is the difference in terms of exposure. Transcondylar approach is beautiful, and it offers more shallowing and a more flat view to the vertebro-basilar junction here, just in case. And this is an overview of the corridors that we can use. Especially, we can describe two corridors. The first one is above the hypoglossal nerve, and the second is below. The so-called suprahypoglossal corridor is the corridors of choice to treat the anterior medullary segment aneurysm, and the so-called infrahypoglossal corridor is the corridors of choice to reach the lateral medullary segment, the caudal loop of the pica here. And also, we can use the suboccipital approach with all of these variations for treating beautifully the pica, the distal pica aneurysm. The suboccipital approach can be the different, shape in terms of craniotomy, and this family of approach can be also tailored. We have three different intradural corridors, median, paramedian, and lateral. It depends basically from where the aneurysm is located. And here we work around the tonsil, especially the tonsillo-uvulary fissure approach is, the corridor of choice to treat those aneurysms that affect the TUFA approach. Tonsillo-uvulary fissure approach is the corridors of choice to treat the so-called cranial loop, or the telovelo-tonsillar segment of the pica here. And distal pica also can be beautifully treated with also the retrosig approach. Distal SCA, ICA, and pica can be also treated with the retrosig approach. I want to conclude my lecture with a slide of Professor Splezze that always say that especially in skull-based surgery and neurovascular surgery, they share the same principle: exposure is everything. Thank you so much for your kind attention.
Thank you, Professor Sabino Lisi. It's an excellent presentation, and as your conclusion, is it true that we need to teach a young neurosurgeon how to make approaches, because it's very important, especially in posterior circulation aneurysm. I know they are maybe one of the rare departments that still continue to operate this kind of location. Thank you. So now
totally agree with you, 100%, as I told you.
yeah. So I will go to my presentation. Mhm. 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 Okay, do you see my presentation?
Yes, Professor.
Yes.
Okay, okay,
You can go ahead.
okay. Thank you. So I'm Dr. Wahabi from Rabat. This is the Department of Neurosurgery in Rabat. And this is the Rabat CT. For those who has been there, Professor Yoko Kato, Professor Zelili, and I hope the other colleagues will one day are invited to come to Rabat. And this is the new neurosurgical department and the new university hospital under construction in the area. So let's go to the presentation. This one of slides I have presented many times in many congresses, just to a reminder about this ISAT study. This ISAT study had an important impact on the management of aneurysm subarachnoid hemorrhage, despite numerous limitations of the study. The result of that, and there is an decrease in the number of aneurysm cases that has been treated since then by neurosurgeon. The aneurysm referred to neurosurgeon became more difficult and more complex. And also, we are now witnessing a new generation of neurosurgeon, unfortunately less familiar with open surgery. However, with the continuous development of endovascular technique, to decade later, we are still, the debate continues. What is the efficacy and safety of coiling versus clipping? And also the role and the endovascular treatment versus clip-in treatment in the endovascular area. Since the publication of ISAT, there has been 3 studies that have, and many observational studies that shown different results from the initial ISAT study. But still, the continuous development of endovascular made it very widespread and used by many neurosurgeons and neurointerventionists. In addition to this debate, the endovascular treatment, we know that has still many limitations and is not the ideal solution for many rupture aneurysm cases. And the main limitations are, first, the durability, because of higher risks of recurrence with time. The complete obliteration rate is still inferior to the result we obtain after clipping, and this has been shown in many studies. There is a higher complication rates with complex devices, fluid diverters, coiling assisted with stent. Complex aneurysm, which are technically demanding, is also a problem of difficulty with endovascular treatment. And in many countries, like countries in Africa, the cost and affordability of devices is one of the big limitations of the development of endovascular in these countries. And from scientific point of view, non-randomized trial available so far to compare the different devices that have been used for endovascular treatment of aneurysm. This group of complex cerebral aneurysm constitute a poorly defined group of technically demanding lesions. And you have seen the characteristic of this group of complex aneurysm. You see there are different features: giant aneurysm, location, a difficult or mobile position, configuration, broad neck, branches ranging from aneurysm, wall structure with blister-like dissection, the calcification aneurysm. So there are many features that make the definition of a complex aneurysm, but still there is no general consensus what is exactly the complex cerebral aneurysm. And in the last few years, there are many authors who try to identify a new group of this kind of aneurysm to be treated with either endovascular or microsurgery or both technique. The complex wide-base aneurysm pose a big problem for endovascular treatment. Patient with tortuous vascular anatomy and accessibility is also a problem of limitation of this technique. Aneurysm with important vessels originating from dome or and mycotic and traumatic distal aneurysm, the blister and small aneurysm with the risk of rupture. In most of rupture aneurysms, the use of stent-assisted coiling and flow diverter requires antipalliatage, what is not safe in this case of rupture aneurysm. And as I said, the cost and affordability of devices also. And when we review the most recent endovascular series with endovascular treatment of complex aneurysm, when compared with the non-complex aneurysm, the total aneurysm occlusion is around 50% versus 70 to 75% in non-complex aneurysm. The recanalization rate is high, and there is very important notion about the rate of aborted procedure. And 25% almost cases cannot be, the interventionist cannot proceed with this technique. And when you have aneurysm that has rupture, the clinical outcome is worse than with non-complex aneurysm. So we review our clinical series to study this kind of aneurysm. And this aneurysm type represent more than 60% of all aneurysm treatment on our series. And this is our series. This is an institutional series about 1,173 patients that has been treated. All of them have rupture aneurysm. This is a big problem still in Africa. 90% of patients are referred to us after rupture and not before rupture. So these are two period of treatment before the introduction on the vascular area in our department before 2005, and then after the introduction of the endovascular area in the department after 2005. And you can see here that in the endovascular area, we treated 822 patients. 30% are 70% are clipping and 30% are clipping. And we have compared the two group of this two kind of treatment to see what is the evolution and also the clinical outcome of this kind of patient. And there are indication for both technique. We consider that patients are better candidate for clipping if they are young, when last 50 years, dysplasic with and wide neck aneurysm, most MC aneurysm, giant aneurysm, distal aneurysm, compressive hematoma, and patient with present with mass effect on cranial nerve. Those patients we consider that are not suitable for endovascular. Of course, all these patients are discussed with our colleague endovascular. The better candidates for endovascular are posterior circulation aneurysm, poor WFNS grades, old patient with symptomatic vasospasm, and the two techniques can be used without a problem in the small anterior circulation narrow aneurysm with the patient very good grade 1 to 2 or 2. And this, for example, aneurysm that's suitable for both technique, the non-dysplasic narrow neck aneurysm, dome to neck ratio more than 2, and no important vascularization coming from the sac. But these kind of aneurysm we consider complex. More than 65% of all aneurysm treated in our daily practice. And you can see most of them are dysplasic aneurysm, mycotic, distal, small and wide neck, sometimes MC aneurysm, distal A1, A2 aneurysm. So these kind of aneurysm, after discussion with endovascular colleagues, we prefer to go for microsurgery because the results are better than with endovascular treatment. And this is just some illustrative cases about this kind of aneurysm. This is a patient presented with dysplasic right ACOM aneurysm after subarachnoid hemorrhage, and and you can see here. This is the dysplasic right A1, A2 aneurysm. After terminal approach of opening of the Sylvian fissure, you can see the optic nerve here, the aneurysm. This is the both I2, dissecting both I2 here. The A1, you see the A1 is dysplasic, and we are going to use a mini fenestration clip to reconstruct the A1 and to exclude the aneurysm sac. This is the first case. The second case is this patient presented once again with large ruptures, wide neck ACOM aneurysm, not suitable for endovascular treatment. And we operate the patient. This is with the broad neck. And After dissection of, there is the small resection of gyrus rectus. And then we dissect the sac and try to define the neck of the aneurysm. There is a temporary clip here on A1. We dissect here the sac of aneurysm and separate it from A2, both A2. We use, once again, a fenestrated clip to reconstruct the parent artery and to exclude the sac. And then we make a control with ICG. We found that the clip just take part of A1 contralateral A1, and then we reposition the clip once again to be sure that it is free. And then we performed a last control, ICG control, to be sure that the final control was satisfactory. The third patient is a patient presented with rupture dysplasic and calcified right MCA aneurysm, the bifurcation with wide neck. And we discussed the case with our colleague, and it was not suitable for endovascular treatment. And then opening the Sylvian fissure. The sac is yellow, dysplasic, with some atherosclerotic material inside. We discussed the dissection of the sac from the M2, M1A2. We try to define a neck. We make some coagulation of the neck just to shrink the sac and to individualize a neck where we can make our clipping. And just to control final control to be sure that the clip doesn't interrupt vascular structure. There is two other patient. This one had presented with internal carotid right internal carotid artery ophthalmic paracnoid which has rupture. And we discuss the case, and we go for microsurgery, and we start by making this is a paraclinoid aneurysm, so we make an anterior cleidoctomy. Intradural cleidoctomy, and we dissect the sac. During this procedure, there's a small rupture of the aneurysm. And once again, we use some fenestrated clip to reconstruct the carotid artery and to exclude the aneurysm sac. Other indication are when the aneurysm is presented with some mass effect on cranial nerve. This is the case of a patient presented with large rupture carotid ophthalmic aneurysm with reduced visual acuity. And we go for microsurgery. And then this is the approach. we performed anterior clinodectomy. And then we dissect the aneurysm. Look, there is the neck here is not very wide here. So we clip the neck and then we go for a decompression and resection of the sac. This, the microsurgery is better here regarding the outcome of the optic nerve compression than the endovascular treatment. And then we resect completely the sac. So this is also a patient presented with third nerve palsy and rupture aneurysm. So we decide to go for microsurgery. This is a large partially thrombosed aneurysm, become aneurysm, and we after this dissection, the neck here, that was the clip in the neck was straightforward, was small neck, and then we open the sac, compress the third nerve to be sure that to relieve the pressure on the third nerve. So our indication, each time there is a compression of cranial nerve, we prefer to go for microsurgery to decompress. And the last two cases, this is one patient who presented with 13 years boy old with the basilar trunk aneurysm with which was not favorable for coiling, and we decide to go for surgery. And this is the aneurysm, the small one. And after opening this Sylvian fissure and the basal cistern, the Leuquist membrane also was opened, and then we get access to the basilar trunk. And we can see here, this is the small aneurysm that is orientated downward. And we use one small clip to exclude the sac. Just we will trying to see what the best approach here. And the last case is a patient presented with rupture basilar trunk aneurysm, not suitable for on the vascular treatment. And after opening the Sylvian fissure, we go for dissect. This is basilar trunk. The temporary clip on the basilar trunk. And then we use a clip, long clip, to exclude the sac, and we control remove the, and we control the aspirate sac to be sure that it completely occluded. That's it. So this is the comparison between the endovascular and the microsurgical clip-in RCD. The clip-in rate of complete collision 90-30% versus coiling 74%. And this is the outcome between the two groups. There is no difference in good outcome in the two groups. So why microsurgical clipping for rupture aneurysm is still relevant in the area of endovascular? I think there are many reasons. The first one is that clipping is well-established treatment modalities for many, many decades, and there is no difference in clinical outcome with ANSAT and other studies, especially for anterior circulation aneurysm. The second is that clipping is superior to coiling regarding obliteration rate and risk of recurrence in all types of aneurysm. And there is a higher risk of rebleeding after coiling at 10 years. The clip-in is the most definitive and durable mean of treatment. The second reason that endovascular technique have still many limitations. The third one is that there is a problem of cost for endovascular versus microsurgery, and you can see in giant aneurysm, coiling costs 13 times clip-in giant aneurysm. So the debate on coiling versus clip-in should be ended. I think there is both endovascular treatment and neurosurgical treatment should be considered as viable option. And we have to think about the patient-tailored treatment strategy should be adopted. So in conclusion, the results of these studies, as many others, shows that in daily clinical practice, clip-in and coiling yield to similar good clinical outcome in rupture cerebral aneurysm, provided the selection criteria for each procedure are respected. The clip-in is still the best treatment option of complex rupture aneurysm than endovascular treatment. A patient-tailored treatment approach in which both endovascular and microsurgery are regarded as a viable option is the best treatment strategy in cerebral aneurysm management. A more inclusive approach with combined endovascular and microsurgical is being developed in hybrid operative room for complex cerebral aneurysm. Thank you. Now, let's go to the next speaker, Professor Nirav Patel. Are you ready?
Yep. Everything looks okay?
Okay, perfect. Good.
All right, great. You know, that's a good segue. I agree. The debate, coiling clipping, is a foolish one. And I'll tell you, from my perspective, I practice both open and endovascular. And for me, the debate is inside. I think of what is my toolbox? I want to be good at clipping, coiling, stenting, bypassing, flow diverters, all the tools. You know, if someone said, I'm going to make a house only with a hammer, no saw, it wouldn't make any sense. So similarly, the world of vascular neurosurgery is one where we as neurosurgeons can have all the tools in the toolbox and have flexible thoughts to arrive at the answer for our patients, ourselves. That's what I think is the debate now. It's not a clip versus coil. So I wanted to just share some cases to tell you how I've been thinking about it. So like this case, I couldn't clip this as safely as I can coil this. Mid-basilar trunk, I went through the radial artery, coil, and a flow diverter. It's a very standard now. It's a good procedure. Before I learned endovascular, I would do a large skull-based craniectomy and find this, and yeah, maybe, but I think this is so much safer. So I think about that. Then you have these ruptured cases, even basilar ruptured cases. And people, you know, we worry about stent coiling and dual antiplatelets. So I'll give you some example. I did this with the stent, and the way we do it, we load the patient on the table, dual antiplatelets, put the stent, put the coils. And when the patient needs a shunt, the EVD is already in place before the DAPT, and we make an incision, cut the catheter, and just connect it distally. So not to replace the EVD, just turn it into a shunt. You know, this saves time and all these things. And anyway, I think it's possible to do dual antiplatelets for ruptured aneurysms. Another basilar, this is a new stent. Why did I show this picture? Because here, you see, as you're going, you can push the stent and make it turn at a right angle and cover the whole neck of the aneurysm. So that's really nice, instead of what we call a Y stenting in order to protect both PCAs with one stent. Another option is to come from the anterior circulation through the PCOM across the basilar top, called a T-stent. And you can coil wide neck basilar aneurysms safely. All of it is now done radial. We do stroke. The stroke I'm about to do is radial. Everything is radial because it's less complications. He comes with a thunderclap headache. Look, you could definitely clip this. I no doubt. In my mind, though, if I can do a good job in this patient and coil this, it's also very fine. Here's another example. She's 39. So you might say, why not clip this? Well, she has bad cancer and she needs surgery for her breast cancer. She needs radiation. You could say, don't fix it at all, but it's a 10 millimeter sentinel headache in this woman. What do you do? So new devices is cool. This is what's called a retrievable stent. So we put the stent only temporarily for the coiling, then coil the aneurysm, then remove the stent. So the patient does not have to be on dual antiplatelets. This lady comes in with a thunderclap headache, right? These cases really I take very seriously. We just get it done, ACOM. Why not? Radial access, put the coils through one A1 and you're done. And the patient can go home. So when it works, it's really, really nice. Another lady, this lady, I bring this case up because it's not about clip coil, it's just about management. Look at this. You can see on her initial head CT there's blood, but she goes from ER to ER. Nobody catches it. And then finally she comes with this flare changes in the MRI. You got to take it seriously. So we immediately, Friday afternoon, let's do it. Other thing about coiling, I think that the more coils I can pack into the aneurysm, the less chance of recurrence. So at the end of the case, if I don't see any contrast, that's good. It's going to work. For PCOMs, if they have a large fetal PCOM, they have less chance, more chance of recurrence. So that's maybe another idea not to use endovascular if they have a large fetal PCOM, just clip it. That's a follow-up, 1-year follow-up, looks good. And sometimes you get this problem. It's true, coiling is not as durable in every patient, maybe 8% in my hands, I think, recurrence, okay? So this lady comes in with the subarachnoid hemorrhage. I coil this PCOM aneurysm, but we follow it. And it looks pretty good, but in 1 year, I see some recurrence. And here you can see a larger fetal PCA type configuration. So instead of recoiling, just go to the operating room, right? If we can do both, why mess around? The first time it was a good try, it worked well, and then I got to move this thing somehow. And then we just go back. And as the great talks this morning already illustrated, it's not that difficult to clip the aneurysm. She had a large clinoid, so intradural clinoidectomy, and then comment. And one thing about this clipping the previous coiled aneurysm, sometimes I use the coils that I placed before as a buttress. So I don't clip exactly the neck, but I clip the dome of the aneurysm. It squeezes the coils down into the parent artery and closes the neck. So that's another thing to think about. If there's not a lot of space, you can do that. And then it's done. It's perfect. Delayed cases, she comes with vasospasm. People think maybe I shouldn't treat by open surgery when the patient is in vasospasm. Okay, so you can coil and that's okay. And then, in fact, after the coiling, which looks very good, it's nicely packed. If you follow it, some of these are going to recur. She had recurrence 1 year. And so we just went and did a clipping of that. And when you clip in 1 year or 2 years later after coiling, the brain is very calm. I find it more enjoyable, instead of the subarachnoid swollen brain. And I think about pica, because some people were talking about pica aneurysms. It's the same way. Why we shouldn't sacrifice the artery. So if you need to sacrifice, go for bypass. But if you can coil it, it's very nice. This is a radial operation. And most of these can be coiled, relatively safely. Then when it cannot, what is not good for coiling? Small ruptured aneurysm like this pica, that's not good for coiling. I'm going to have a trouble. If I push the limit, if I push my limit, I say, oh, I'm going to put a flow diverting stent. Well, I think that's doing the patient a disservice, because that has a higher complication rate. In this situation, it might not even work. Perhaps it's just better to go to the operating room, and you make that decision. Like I said, it's just tools in the toolbox, my toolbox. What can I do? Not everything is a hammer. And if sometimes picas can go very well, look at this one. She came, I thought it went great. We coil this, she's 70 years old. It's perfect case for pica coiling. But it came back. So far lateral, straightforward, and we're done. So my point to this is, if we try coiling, which I think we should, 10% recurrence, and then just fix it, clip it, be done with it. If the patient has this kind of aneurysm, dissecting proximal pica, I'm not going to do an endovascular obliteration because of the perforators. And if I just occlude the pica, he will end up with a stroke. So I think it's important for us as neurosurgeons to ensure that if the radiologist or the neurologist doing interventional wants to sacrifice an artery, I think we ought to think about bypass and suggest that instead of allowing the stroke to happen, right? So for that dissecting case, it's better to go to the operating room and be done with it. In this case, I did a side-to-side pica bypass and then trap the segment. This was a case from outside, and I don't have a right answer to this, but I share it because more of these kind of sidewalled pike aneurysms are being flow diverted. But if you flow divert it and then you run into a problem like this, is growing basilar type, medullary compression, the guy's in a wheelchair, it's terrible. Then occipital pica bypass and be done with it. Again, my story is that I don't have to stick with just one solution. You start with start with clipping and you can end up with coiling, or you can start with coiling and end up with clipping. I'll show you those cases too. Now, on the other side, the paraclinoid aneurysms, I think, is very good flow diverter. We don't find very often the need to clip these aneurysms, but if we have a need, no problem. Like this lady, I clipped one side and flow diverted the other side because of the anatomy. And I don't want to keep showing the videos. Everybody showed the videos so beautifully, but the endovascular videos is also beautiful. There's nice to learn the techniques and to be able to take care of these cases. Like this is a balloon assisted for superior hypophyseal aneurysm. It's very straightforward. I think it's a nice approach, safe, less complications to the optic nerve in my hands. Now, the older patient, perfect for coiling because it's a narrow neck, large aneurysm, and even with visual changes, those changes come back to normal after a little bit of time. And for older patients, I don't think I need to be as aggressive with the perfect coil. They can tolerate this. It doesn't have to last as long. This is the lady with the superior hypophyseal aneurysm, 8 years post. The other thing about what I learned about coiling, if it doesn't recur in the first 2 years, it doesn't seem to recur. The recurrences happen initially. This lady's a ruptured ophthalmic. I think most people nowadays would opt for endovascular treatment. Certainly you can clip this aneurysm. It's a good one to clip, but I coil it, There's a little bit of recurrence. Later, I added a flow diverter outside of the initial rupture. And then that takes care of it. I don't want to give you the impression that, that we always end up having to do a second surgery, but I wanted to share those cases that I can recall that needed something more, because I think we just need to be flexible of this. Let's skip some of these. Recurrent, the flow diverters through the radial is very nice. It decreases the hematomas in the femoral artery, and you get a good result. Here's one where I started with open. So take a look at this. So here we have a bad case, high grade. So what's going on here? And you see the problem at the supraclinoid carotid. And, blister aneurysms are just hard. Yeah, no matter how you do it. In this case, I opted for flow diversion. And we place the EVD first, then, it's easier to do dual antiplatelets on the table. And now we have integralin, so it's an IV formulation of an antiplatelet medicine, a double stent, and that works well. But how about this? So the opposite is also true, where in this case, I did surgery, right? Everybody would agree this is a good case for open surgery. I did a high flow bypass to the distal M2, and I it went well. And then I'll show you what happens. So there's perforators, so we don't like to lose those perforators. That's why even a flow diverter might be a little dangerous. We do the saphenous vein, and just standard high flow bypass. But look at this. So you can see that even post-op day 7, everything looks so nice. The aneurysm is nearly gone. Post-op day 21, it looks perfect. And look what happens. 5 weeks, she has a giant recurrence with a hemorrhage. So in this case, then I combined, I just took the operate to the endovascular suite and coiled it. And that was the end. So in one case, we started with open surgery, ended with endovascular combination, and the alternative start with coiling and end with clipping. Here's one where it's a giant ruptured case. And because I thought, well, maybe I don't want to do a high flow bypass right away, I will place some coils, temporize the patient, and then, see, these are the coils, sorry. Oh. Here's the coils, a partial coiling of the ICA terminus, partially thrombosed aneurysm, and then the vein bypass to finish the day, combining these things. And like you mentioned, in the hybrid suite, it's a really nice to be able to do both with the head open and to have angio at the same time. Now, these webs, people use these webs. I don't think they're very good. I'll be honest. I think the failure rate is significant. This is a case where the web was placed in the ACOM. This is an endovascular endoluminal basket. And the guy ended up rupturing later. It was an unruptured aneurysm. Web was placed. He ruptured 1 year later. This is amazing. And you can see the bleed here when I went to surgery.
This video is about the surgical repair.
Oh no, I got the volume. So that web, it acts like a atherosclerotic aneurysm. You have to crunch it a little bit, like cholesterol-laden walls, So for that, you can use the fenestrated clip for the increased distal closing force, and then just do it like you would for an atherosclerotic aneurysm. I want to make a point about another thing here is that MCA aneurysms really should not be coiled. I mean, very rarely. Like if it's an 80-year-old patient with a narrow-necked MCA, it's ruptured, okay, I would do that. But I think MCAs we really ought to be clipping, except for the occasional case. Look at this. So this is a flow-related fusiform distal MCA. And it's nice. Like if I operate, probably I'll do a STA bypass and trap, or because she's a little bit elderly, we can go radial and place a flow diverting stent across the neck of this distal MC aneurysm, and it works nicely. I guess in the end, I want to find my least risk solution for these patients. So here's a ridiculous case, and I'm going to end with this case because this is what I see more and more. This is a patient that's an outside hospital. He had a 3mm MC aneurysm. Look at this is 2015. A double stent, Y stent, and coil. I mean, first of all, I don't know. Maybe I wouldn't treat this, but anyway, it got treated. And it kept growing. Now, giant. And more coils were put in. And more coils. And third time more coils. And it's a mess. Poor guy. And I know everybody has good intention. I'm not blaming the surgeon at all, but this maybe didn't need to be that way. So now he comes, and now we have to have a better definitive solution, and looks good for open surgery. A lot of different options, but this is what I opted to do: is a distal bypass and then trap the segments. That's probably became too complicated, straightforward cases, and that's just the way it is. So maybe we don't need to do that. If more of us are clipping MCAs, we can avoid that problem too. But anyway, in summary, what I'd say is my thought process is these are tools in a toolbox, and that should be mastered by neurosurgeons and commanded by neurosurgeons, and be able to be flexible in thought. When one fails, change and augment the repair with a different strategy. That's about it. Thanks.
Thank you very much, Professor Nirav. This is very balanced, I should say, presentation by putting both techniques and in the hand of the same neurosurgeon. This is very important just to avoid some bias. If there is this kind of decision is proposed by another colleague, not neurosurgeon, who has no idea about the microsurgery. In your situation, I think it's very easy to choose for the patient. So can we go to some discussion? If there is any question, please. Professor Kato, have any comment, any question?
Yes, thank you very much for all the three speakers. It was a great talk. Thanks so much. Congratulations. So just I want to ask Dr. Nirav, endovascular neurosurgeon. So as a point of the minimally invasive treatment for the patient, I think in the future is no more coil. Just maybe I think stent, or maybe the web. You do not like put the stent, the web. But in our institute, we have so many cases. I think maybe calculation is very important. Axis and calculation is very, very important, I think, for when we use the web. And once the that we can use the web. I think it's the best way for the patient because it can be used in the ruptured or unruptured, both situation, I think. Now, how do you think about in the future endovascular direction?
Yeah.
Just this is no, please.
For the web, we were involved in the initial trial for the web in 2014, 15 randomized trial, and the reason I'm not sold is because so many of the patients years later have come back with a recurrence, up to 30%. And you write that wide neck aneurysms, if we're going to treat endovascular, they're better not to be stent coiled. Like it adds the risk as a stent coiling for dual antiplatelets. So I think as the devices improve, for example, coil only web, so that is a real thing now that we're going to see more of, where we coil into the aneurysm, but it also has a cup, and it sticks inside the hole of the aneurysm. So it acts as both a stent and a coil. You're going to see that in the next few years. I do think wide neck aneurysms are going to be more and more endovascular. This is true. The other thing I'd say, though, is some diseases, diagnoses, are not going to be endovascular. So, for example, moyamoya disease is open vascular. It's a bypass. There is no endovascular solution. AVMs, in my opinion, like I have shared with you all, that I think is completely open vascular, open. No embolization, clip the arteries, surgical embolization, then resect the AVM. But stroke, thrombectomy, that is an entirely endovascular solution. You know, nobody anymore, well, rarely do we need to go to the operating room for open thrombectomy. Now the cases are much more endovascular. Cavernoma, that's an open case, right? Cavernoma is no endovascular. So there are still diagnoses that need always open surgery, and there are diagnoses that need always endovascular. Aneurysm is changing, more and more endovascular.
Okay, thanks a lot. Thank you very much.
Another question. Just question for Professor Lucy. How do you convince your colleagues in endovascular for posterior circulation aneurysm to operate rather than to go for endovascular treatment? Is it your choice or discuss together? I mean, for the best treatment option?
I'm very lucky because I don't have a Professor Patel in my hospital, so they're not so good like him. I love Nirav because he's so good and so skillful. Otherwise, he does disaster. Most of the cases, you know, especially for pica aneurysm, distal aneurysm, thrombosis aneurysm, we discuss a lot. But for sure, if you work in the same hospital of Nirav, it's you can get in trouble there. I'm joking, Nirav. You know that I love you. Yeah. Anyway, it's difficult. We discussed about. There is no question about the role for surgery for thrombosed aneurysm when we need revascularization revascularization procedures, and those aneurysms that are very close to perforator, especially in some cases of distal pica or proximal pica also. You know, pica it's still probably a field. There is still a role for neurosurgery. It's a hugest role for neurosurgery. For sure, it's not the same for basilar tip, but when basilar tip, it's huge, it's giant, there is, you know, few questions about the indication for surgery, especially because, you know, we talk about some aneurysms that sometimes can cause some mass effect. And thank you so much for having shown some beautiful cases, Professor Cado, you, Professor, also showed some beautiful cases of paraclinoid aneurysm. Okay. For 3/4 of paraclinoid aneurysms, I totally agree with Nirav about the fact that, you know, they were born, pipeline stent was born for that kind of aneurysm. So there are a few questions about the indication. But for those giant ophthalmic, so superior projecting aneurysms with compression of the optic apparatus, there is a question about the fact that probably decompression of the optic nerve of the optic apparatus can be indicated also in these cases, especially because especially for giant area, as more clip, the more coil you put inside the aneurysm, the more the mass effect of the aneurysm and the risk of acute thrombosis also. So sometimes even for stents, you know. So that's the reason why for that kind of aneurysm there is a role for surgery, and we discuss about lots of this aspect.
Professor Cato, I just question in your clinical practice, what are the percentage of patients that still you operate by microsurgery versus endovascular? I mean, especially for complex aneurysm.
Yes, it's getting less and less for open surgery, but Radioluzzi that he mentioned about the partially thrombosed one, it should be the role for the open surgery. Thank you.
Can I ask, in Morocco, when the patient comes, do they have to pay for the coil and the stent ahead of time? And how do they generate that much money? What, you know, that's a real problem for the patient and their family. And that's probably why we should, in all of the world, still have great microsurgeons. You know, that cost is prohibitive.
Okay, in Morocco, in almost all public hospital, there is like a public insurance that's cover part of the expenses, but not all part. I mean, for a flow diverter, $10,000, it's not possible. But less than 5,000, it's okay. So it depends on the situation of the patient. He has from time to get from his pocket. This is the big problem.
I also have a small question for Professor El Awabi, if I can. Can I?
Good, please.
Professor, you showed the beautiful cases of anterior communicating artery aneurysm, but what's your choice about side approach selection for anterior communicating aneurysm? You always go from the, you know, dominant side, or sometimes you prefer to choose about the twisting angle of the anterior communicating? Because
I understand your question. Yeah, it's very interesting.
Yeah.
Most of the time we go from the dominant.
Dominant. Yeah,
Just
totally
in case,
agree with you.
because
Yeah,
patient already has rupture aneurysm. I don't want to have a second aneurysm, and you are not sure that for the temporary clipping.
Sure.
You have to be this is most of the case.
And you showed the beautiful video about posterior projecting. The posterior project are the most complex one, because the dead spot is the aneurysm, not the parent artery. So they're beautiful. Congratulations. Thank you once again.
Thank you very much. Thank you. Dr. Nirav, I have a question for you now. In the States, in your department, sorry, Dr. Nirav, in your department, I have a question. I mean, when you have to teach a young neurosurgeon both technique, or you have to influence them to choose one technique above the other. My question is, sometimes it's easy to go for endovascular treatment, but the result after 1-2 years after you've shown, we expect some recurrence. In comparison, if you go for a definitive clip-in technique, which may be some difficult sometimes, so the young people maybe choosing the less invasive but less difficult at the time. What do you think about this? Can you put him on, please? Can you put him, unmute him? Dr. Zelili? Don't know what happened.
Unmute. Hello?
Yeah.
Okay.
Okay, great. Thank you. I got muted. Sorry about that. It's a great question. It's one that I struggle with. We have 2 endovascular fellows. They're fully trained neurosurgeons, and we train them in endovascular. We are supposed to also train them in open vascular. But what happens, to your point, they spend most of the time in the angio suite because they're trying to learn everything endovascular. And they already did 7 years in neurosurgery, but that is not the same as a dedicated open vascular fellowship. So for the unique individual, occasionally the fellow comes, he wants or she wants to learn both. I think the ideal is 3 years. One year open, 2 years endovascular. Now, that's rare people, right? Because that's 10 years of training. We don't see that very often. Your point is correct. Majority of neurosurgeons who are practicing endovascular, they come out and they continue doing endovascular 90%. Some of them give up the open completely. I find it necessary to excite them with open surgery. And, like training in rat labs, training in bypass surgery, allowing them to throw some sutures if they get good enough, AVMs. And I talk in a dogmatic way, partly because I need to get these people interested, and they have to see that they should practice both with a real love, a passion of microsurgery and a passion for endovascular, that you have to cultivate that. It is not apparent, because on Saturday morning, you want to be with your children and an aneurysm comes in, it's so much easier to coil that aneurysm. You know it, right? But if you think in your mind, it's a wide-necked ACOM. If I injure that person forever, I'm out. So maybe I'll clip it today. And that's a scary thought for a new surgeon. Very scary. I don't have the right answer. All I know is that we as a group have to keep supporting neurosurgeons who are trying to learn both.
Thank you.
Dear Abdul Samad, I think we have to stop this panel now.
Vascular neurosurgeons are all the time speaking about this problem. Thank you very much.
Thank you.
Thank you. Thank you so much. Okay. It was
Thank
wonderful.
you
It
so
was great pleasure to have you all. Thank you.
Thank you very much.
Thanks a lot.
Bye.
Bye.
Now, goodbye. Now
Bye.
we will switch to the other panel. It will be on management of craniocervical junction tumors. And then I ask Dr. Alvaro Campero to moderate the session. Here, Alvaro.
Hello, everyone. Thank you very much. Well, we start with the program. And first of all, Dr. Abida Shah will talk about anatomy of cranial. Please, Dr. Shah.
Yes, hi. Thank you, Dr. Alvaro. Can you see my screen?
Yes, perfect.
Okay. So thank you, Dr. Girelli, for this invitation to this wonderful webinar. And let us start the management of craniovertebral junction problems by learning the anatomy of this region. So this is an image which shows wonderfully this area that is a transition zone between mobility and stability, and also a transition zone between the brain and the spinal cord. So it is a narrow passage where a lot of critical neural and vascular structures pass through. So it is important to understand the anatomy of all these structures that are there in this region. The next important thing is the bony hallmarks of this region are important for the stability, that is the occipito-atlantal joint, and the mobility of the neck, that is the atlantoaxial joint. So all of these structures that you can see here are involved by pathology in the region of the craniovertebral junction. And let's look at the anatomy and the pathology of this region. So the craniovertebral junction is made up of 3 bones primarily: the occipital bone, the C1 and the C2. So the occipital bone has three parts: the clival part, the squamosal part, and the condylar part. So this is the rim of the foramen magnum, which is formed by the parts of the occipital bone as they join together. And this is the occipital condyle. As you can see, they are facing convex downwards, and they're directed forward and medially. As you see, for the orifice of the foramen magnum, it is wider antero-posteriorly rather than transversely. Then this is the squamosal part of the occipital bone, which has a series of lines, that is the highest, the superior and the inferior nuchal line, which give rise to several muscular attachments which are important in the region. And we'll see these layers one by one. Then the next important thing is the hypoglossal canal and the condylar canal, which transmits the emissary veins in the region, connecting the vertebral venous plexus to the sigmoid sinus. So here you see a close-up view of the condyles that are facing convex downwards and directed forwards and medially. This is the rim of the foramen magnum. This is the clival portion. This is the squamosal portion. And this is the jugular part, which connects to the temporal bone. The next important bony landmarks in this region are the atlas and the axis that form the atlantoaxial joint and are important for mobility in the region. So as you know, both of these are atypical vertebrae. They don't have a proper body and a spine. This one does not have a body or a spinous process. So this is the C1. There is an anterior tubercle and a posterior tubercle, and an anterior and posterior arch, which are connecting both the tubercles. And it has a large bone, that is the lateral mass of the atlas. This is the superior facet, this is the inferior facet, and this is a thick area of cortical good bone that can be used for purposes of fixation. The transverse process has a groove in which runs the vertebral artery, and we will see how the vertebral artery runs as we go further. This is the other atypical or magnificent bone, that is the axis. It has an odontoid process, a body, a pedicle, a lamina, and it has also two big superior and inferior facets. The vertebral artery again forms a groove here and runs laterally. The important thing in this bone is that the vertebral artery might run and create a deep cut in the superior facet, creating a high riding vertebral artery whose anatomy is important to understand while passing a screw in the C2 pedicle. The second thing is, if you see all the subaxial cervical vertebra, the facets are one on top of the other. So the superior facet and the inferior facet articulate with each other. But in the C2, you can see that the superior and inferior facet are separated by this ridge of bone, that is the pars interarticularis of the C2 bone. This has a thick, stubby spinous process, which gives rise to a lot of muscular attachments, which are again important to understand. So let's go and see step by step, dissecting away the whole craniovertebral junction. So this is the posterior aspect of the neck. I would like to thank Dr. Sukhdeep Jawar, who is my associate, for providing me with some of these images. So once you open this region, there are three layers of muscles in the craniovertebral junction. The superficial layer is made up of the trapezius and the sternocleidomastoid. The intermediate layer is made up of the splenius capitis and the semispinalis capitis. And the deep layer are the suboccipital muscles, which form the suboccipital triangle. So the first layer consists of the trapezius and sternocleidomastoid. Once you remove them, you see the splenius capitis, which is now reflected laterally, as you can see here. And then you will see the semispinalis capitis. So the splenius capitis is attached laterally and goes on to the spinous process goes on to the articular process of the cervical and thoracic vertebra, whereas the semispinalis capitis is attached medially in between the superior and in the inferior nuchal lines. So this is a closer view of the splenius and the semispinalis capitis. Also, you have the longissimus capitis in this region. Now, once you remove the semispinalis capitis, you will see the muscles of the suboccipital triangle. So on this side, you can see the semispinalis has been retracted, and here it is still present, both the splenius and the semisplenius. So, and here you see the muscles of the suboccipital region. So these muscles form an important triangle here, which houses some critical neurovascular structures. So what are these muscles? So this one here is the superior oblique. This one here is the inferior oblique. This one is the rectus capitis posterior major, and this one is the rectus capitis posterior minor. So the superior oblique runs here from the nuchal lines and goes on to the transverse process of the axis vertebra. The inferior oblique arises from this transverse process, and goes on to the spinous process of the axis. The rectus capitis posterior major arises between these nuchal lines and goes on to the spinous process of the axis. And the rectus capitis posterior minor, which is hidden by the major, goes on to attach itself to the posterior tubercle of the atlas. And within its boundaries, you see this area, and that is the region of the suboccipital triangle. So again, this is a close-up view showing all the muscles. So you see how the spinous process of the C2 has so many muscular attachments to it. So this is the superior oblique, this is the inferior oblique, this is the rectus capitis posterior major, and this is the rectus capitis posterior minor. Now let's look at the contents of the suboccipital triangle. So the floor of this triangle is formed by the posterior atlantoaxial membrane. As you saw earlier, it was covered nicely by the semispleninis capitis. And inside it, there are two major structures, the vertebral artery and the C1 nerve root that is running on the groove on a posterior arch of the atlas. So look at this here. This is the arch of the atlas. This is the vertebral artery. This is, of course, further down the region of the C2 ganglion, which we will see later. So this is the region of the suboccipital triangle. And here now you also see the other content in this region, and that is the C1 nerve root. So these are the two main important contents of this region. And also you will see these blue structures that are the venous lakes that are present in this region that grow all the way following it into the vertebral venous plexus. So this is heavily laden with veins, important to remember when performing surgery in this region. Now this muscle that you see here is the rectus capitis lateralis muscle, and that is again another important landmark in the far lateral approach to the craniovertebral junction. So coming down now here, so laterally you see, this is the C2 spinous process, this is the C1 arch, this is the C2 lamina going on to become the pedicle. And this structure that you see here coming out from the spinal canal is the C2 ganglion. And beneath it is running the vertebral artery in the transverse foramen of C2. So the vertebral artery comes out in the transverse foramen of the C2, goes up, then curves laterally, and then comes back again medially to run on the posterior arch of the atlas in the suboccipital triangle. And then it runs forward medial to the occipito-atlantal joint, which you can see in this region. Sometimes it is covered by this bony canal. Sometimes there is no bony covering here, but in this specimen, you can see there is a bony covering which has to be exposed if you want to expose the vertebral artery in this region. The next important structure that you see here, which I showed you, is the C2 ganglion. And just beneath it, making an appearance now, is the C1-C2 joint. So once you elevate this ganglion, you will see the C1-C2 joint. So now looking from a posterior aspect, you can see both the rectus capitis posterior minor muscles are maintained. This is the posterior arch of the atlas. This is the C2. These are the C2 ganglions on both the sides. And these are the vertebral artery on both the sides. And here you can see on both sides, there is a bony groove that is being formed, covering the entry of the vertebral artery into the occipital atlantal joint. Now going further, on the right side, I have reflected the C2 ganglion. This C2 ganglion gives out an important dorsal ramus, which goes on to supply the muscles, and it is the greater occipital nerve and supplies the muscles and the skin on the nape of the neck. Once you deflect this ganglion, you see this C1-C2 joint. So this step is one of the most important steps while performing surgery for basilar invagination, where you might need to cut the ganglion. And Professor Goel has described this step as cutting the ganglion and making a window to the atlantoaxial joint. So this is a very important landmark for surgery for fixation in the C1-C2 region. This is on the other side where you can now see the entire course of the vertebral artery as it is coming out from the transverse foramen of C2. So again, another important landmark here. If this artery is high riding, it will run up right to this point, making a groove in the superior facet of C2. And then you have a very narrow region of the C2 pedicle in which you have to insert the screws. So another important CT anatomy that you should look for when you're performing fixation in the C1-C2 region. So again, here going on the posterior arch of the atlas, the vertebral artery and the C1 nerve root. Now we are opening the dura. Here you see the sigmoid sinus. So from posteriorly now, a suboccipital craniectomy will be performed, and all these spinous processes and lamina will be removed to look further into the region of the craniovertebral junction. So now the craniotomy has been performed, and here you see the dura is opened. Again, this is the sigmoid sinus. Lower down, the arch of the foramen magnum and the C1 has been removed a little bit. Now the whole spinous processes and lamina of the subaxial spine along with this foramen magnum rim is now removed. And let's see what's inside these structures. So the first thing that you come across is this C2 ganglion as it exits from the spinal canal. You see, this is a very large ganglion. And another important thing is that most of the ganglion is extradural. There is no component of it intradural. This is again another an anatomical concept that you should understand, which is important while performing surgery in C2 neurinomas. So now you see this is the vertebral artery as it is entering into the cranial compartment medial to the occipito-atlantal joint. Now you see the cranial nerves in this region. So I will take a closer view of this region. Now you see this is the vertebral artery. This nerve that you see coming from down is the spinal accessory. Here you see the lower cranial nerves as they are entering into the jugular foramen. You see that the 9th is running in a separate canal and the 10th and the 11th nerves are running close together. That is the 7th, 8th complex. And more medially, you will see the hypoglossal nerve. So this is, and here underneath all this, you will see the vertebral artery as it is passing medial to the atlanto-occipital joint. Now, this structure that you see here is the denticulate ligament. This is a sheet of pia mater that comes out between the dorsal and the ventral rootlets of the spinal canal and goes on to attach laterally to the dura. The relation here is that the posterior, the spinal part of the accessory, the spinal accessory nerve is posterior to the denticulate ligament and the vertebral artery is anterior to the denticulate ligament. So that is an important relation to understand while performing surgery in this region. Again, you see the vertebral artery as it is entering medially. Now you see the rootlets of the C2 ganglion and they're coming out into this huge C2 ganglion, which is lying just in front of the atlantoaxial joint. Again, now just elevating the C2 ganglion will give you access to the atlantoaxial joint. So there are important things here. There is a series of venous lakes. One is in this extradural compartment that you see here. One will be in this region of the vertebral artery. Hence, surgery in this important is a game of course, knowing the anatomy of the vertebral artery, but also managing the venous bleeding in this area, which is a high deterrent to this surgery. So you have to learn how to manage the venous bleeding so that you can expose the atlantoaxial joint and perform the fixation surgery. Now here you see the denticulate ligament more clearly. You see the spinal accessory nerve. You see the vertebral artery. Here the denticulate ligament is removed and you see the vertebral artery and the C1 rootlets. Now this region where the C1 rootlets come out, this is the transition zone between the medulla and the spinal cord. So up till here, you call it the medulla and just beneath it, you will call it the spinal cord. Now coming laterally, once you remove this squamous part of the occipital bone and the jugular process that connects the occipital bone, you will see the course of the lower cranial nerves as they are coming down. This muscle is again a landmark separating these two parts. This is the rectus capitis lateralis. This is the sigmoid sinus as it continues into the internal jugular vein. And as you remove this region, you will see the course of the lower cranial nerves and the hypoglossal nerve as they come down here into the neck. So this is how they lie anterior lateral to this rectus capitis lateralis muscle. As you can see this cranial nerves in this region. A closer view showing the lateral part, the vertebral artery, the lateralis, rectus capitis lateralis, and the cranial nerves going down between the jugular vein and the carotid sheath. And that is the anatomy of the posterior approach. When you come laterally, this is how you will view the anatomy. And an important structure here is the occipital artery, which is important to preserve when you want to perform an occipital bypass in this region. Of course, you see the anatomy here, the C2 ganglion. And as I told you, there are a lot of venous lakes here. So this is the extradural venous lake. This is the venous lakes surrounding the vertebral artery. And these are the venous lakes surrounding the vertebral artery at the posterior arch of the atlas. Now, just quickly, I will just show you how this anatomy is relevant for the surgery in this region. So this is our concept of C2 ganglions. So as I showed you anatomically, this is an entirely extradural structure. And C2 ganglions, earlier we had divided them into three. We thought this part of it was intradural and these were extradural. But now we all believe they are interdural. So they are between the layers of dura and you do not need to remove any part of this bone to gain access to this region and remove this C2 ganglion. So this was the classification on our papers on the subject. And this is just a video where you see this is the spinous process. This is the arch of the atlas. And here you see the enlarged C2 ganglion with the C2 neurinoma. And you see that we have not removed any bone in this region. You just make a cut here. You open the dura, you go interdural. You open the first layer that is covering the C2 ganglion, and you're able to remove the whole C2 neurinoma without actually going through or removing any spine. Now you can see the whole shape of the C2 neurinoma. This is the interdural component that is causing compression of the spinal canal, that is spinal cord, that is now coming out. And you see in one whole bulk, here you see the rootlets of the C2. So sometimes the dura, there might be some CSF coming in from this, which you can just close down with a muscle patch or a piece of fat. And here you see, without doing any bony work, the whole C2 ganglion can be, C2 neurinoma can be removed just by understanding the location of the C2 ganglion and its relation to the other structures. Now, the next, of course, the most important part in this craniovertebral junction is the fixation for the C1, C2 region, which is important for atlantoaxial dislocations, for basilar invagination, as you all know that Professor Goel has revolutionized the treatment of this craniovertebral junction. And I will just show you a few steps quickly. So this is the patient who presented to us with a Chiari, a syringomyelia, a 12-year-old male child, and he also had atlantoaxial dislocation. As you can see in this image, this is the flexion and extension, and you see there is a mild change in the atlantodental interval. The facets are normal. This is the position of the patient. This is the floating head position. And you see we give a head high position to avoid the venous bleeding in this region. And this is the incision with the centroid on the C2 spinous process. This is the C2 spinous process. This is the lamina of C2 going forward and dissecting in this region. Nowadays, we do not dissect or cut the C2 ganglion because we are able to elevate it and get into the C1, C2 joint. But of course, in cases of high basilar invagination, we cut the C2 ganglion. So this I'm just dissecting on the lamina to reach the C1, C2 joint. And I've opened the joint in this region. As you can see, my osteotome is now entering it. So here in this bunch is a lot of venous lakes and the C2 ganglion. And now that region there you see there is the C2 joint, C1, C2 joint. Now the C2 lamina is being drilled because we use a plate and screw construct for fixing the region. So to keep the plate settled in nicely in this region, we perform a drilling of the C2 lamina. And then an osteotome is inserted, and here you see the C1, C2 joint. This is the joint. This is the superior facet of C2. This is the inferior facet of C1. Here you see the whole joint is exposed. And now a drill hole is being made into C1, which is directed superiorly and medially towards the anterior arch of atlas. After this step, we insert a lot of bone graft into the region because ultimately it is this bone graft that will hold the fusion. The screws will hold it only for a short time. The fusion will occur in this region, in the region of the C1, C2 joints. After doing this, the plate and screw construct is inserted. And then the C2 pedicle screw, which is the most important point here. So the direction of the screw is also superior and medially, and you should go on this region, the pedicle pars region, as high and as medial as possible to avoid injury to the vertebral artery. And once you have drilled this, you can maneuver the plate in this region and then put in the C2 screw. So this is performed on the other side as well. I will not show that part. And then the last step of this surgery involves dissecting the muscles of this region and disconnecting all the muscles from the C2 spinous process, because otherwise your implant will not be as stable if there is some movement that is going on again and again. And then you put a lot of iliac crest bone that we have harvested across this region to continue to help with the fusion. So that is so we saw the pathology of the C2 ganglion. We went on to the bony region, that is the C1, C2 joint. The next important tumor in this region is the foramen magnum meningioma. And again, we use the conventional posterior suboccipital approach for these ventrally placed foramen magnum meningiomas. Here you see both the vertebral arteries are just, one is within the tumor, one is just abutting the tumor. And here you see the post-op images. I will again show just some steps. So this is the craniovertebral junction. This is the dura that is opened. So on one side, unilateral midline suboccipital approach. Now you see all the anatomy. So this is the arachnoid. Here you see the spinal accessory, the denticulate ligament we are cutting now. And now you see the tumor. This is the C1 nerve root. This is the spinal accessory. and now make space between all these critical neurovascular structures to attend to the tumor and then remove it slowly. This is the cerebellomedullary fissure, and the cerebellum is being retracted upwards. And slowly, you know how to, learn the art of dealing with the tumor and breaking it bit by bit, and then removing this tumor from this approach. So I will just go fast. And as you go on, you will be able to resect the tumor. Many of these foramen magnum meningiomas are quite firm. And you have to know where you can remove the tumor, where you have to dissect it from critical portions and remove it. So now you see the vertebral artery coming into play here. So this is the vertebral artery. This is the part of the tumor that is anterior to the vertebral artery, which is now being removed. These are the lower cranial nerves which are entangled and have to be separated from the tumor, as you see here. So this is one of the lower cranial nerves. And you cannot damage any of these lower cranial nerves while performing the surgery. So you dissect it out. It's actually wrapped around, the tumor is actually wrapped around the lower cranial nerve, and you have to cut it and then reflect it around the nerve and then remove the tumor, as you can see here. And just get the lower cranial nerves out of the way and preserve them completely. There's the other cranial nerve also. Here you see the other one, which will also be now released from the tumor. And now you see that the whole tumor is removed. This is the attachment, which will be coagulated. And then you see the anatomy of the region quite nicely. This is the whole vertebral artery as it is going on to become the basilar. And here initially we saw the spinal accessory, we saw the lower cranial nerves. And that is the anatomy of this whole region that can be seen while performing this foramen magnum meningioma patients. And we do all our patients by this midline suboccipital approach. This again, another interesting pathology that is completely ventral to the craniovertebral junction. And again, I've recently operated this case pre-pontine, going all the way to the cervical. This is not this one, another one going all the way to the cervicomedullary region. I've not got the images of that one, but operate again by a posterior midline approach. So this is an endodermal cyst. The important things, you see that they are hyper on T1, they are hypo on T2, and on CT, this is how they appear. This is a very important location there, but the fluid within them is pus-like green in color, and you can easily suck it out by a small approach to the posterior avenue of the craniovertebral junction. The cyst wall you should try to remove, but if it is too adherent, because you should leave some behind without damaging any critical neurovascular structures. And the last thing is there are some pathology in the anterior aspect of the C1, C2 region, which we know as retroodontoid mass. A lot of people do surgery for this mass, but they have to realize, and this was first described by, again, Professor Goel, that this retroodontoid mass is a reaction to the atlantoaxial instability and is an indicator of atlantoaxial instability. And we now have done a lot of cases in this region. So this is not a tumor. It is just it's a retroodontoid pseudotumor. And all you have to do for such patients is do a C1, C2 fixation, as you can see here, and the retroodontoid mass disappears, sometimes immediately and sometimes after a period of 3 to 6 months. So that ends my presentation on the anatomy of the craniovertebral junction. I thank you very much.
Thank you very much, Dr. Shah. Excellent lecture. The next speaker, Dr. Manas Kumar Panigrahi, and he will talk about posterior approach to craniovertebral junction. Please, Dr. Panigrahi. We are not listening.
Okay, can you hear me?
Yes, perfect.
Please start from the beginning. We didn't
Yes.
we couldn't hear you.
Yeah, good evening. Sorry for the hiccups, of the technical hiccups. I'll be speaking on the posterior approaches to the cerebrovascular junction tumors. And Dr. Abida has already stressed that all of them can be done through the posterior approach. But in my 15 minutes, I'll explain which are the cases one has to do through a posterior approach and which are the cases probably one needs alternative approach. As all of us know that the foramen magnum tumors are tumors which involves the lower part of the clivus till the upper border of the C2 body anteriorly and posteriorly from the rim of the occipital scama to the upper part of the C2 lamina and laterally from the jugular tubercle till the C2 lamina. Now, these are any tumors arising or attached in this region is called as foramen magnum tumors. So they can be classified into anterior or anterolateral or posterior depending on the attachment in relation to the dentate ligament. Any tumor in front of dentate ligament is an anterior, and if the tumor is attached ventrally to the midline on either side, it's called anterior. But if it's attached from midline till the dentate ligament, it's called anterolateral. And if it's behind dentate ligament, it's called posterior and or posterolateral. This is more important in meningioma, but also it's important in neurinomas and eventric cysts also. Now, lesions in the foramen magnum, fortunately, most of them, like 50% of them, are posteriorly located, either posterior or posterolateral. So they can be operated with a posterior approach. But then only 20% are purely anterior and 24% can be anterolateral. So this 40% group, one has to think whether they can be done through a posterior approach or one has to have an alternative approach for these cases. Unlike meningiomas, 80% of them are attached anteriorly or anterolaterally, and we have a separate lecture on foramen magnum meningiomas. But as a general rule, when you take all the foramen magnum tumors, 50% of them are behind the dentate ligament, so they can be operated through the posterior approach. If one looks at the different surgical approaches of the tumors of the foramen magnum, there are many approaches described. The posterior approach, the lateral approaches, and the anterior approach. But then anterior approach is not very popular because it's the chances of infection is higher, the CSF leak is higher, and it is restricted by if the tumor is extending laterally beyond the internal carotid, then one cannot excise ventrally. But with the use of endoscope, few cases, especially extradural tumors, people have tried doing with an anterior approach. Many people have tried with transcondylar, extreme lateral, mobilizing the vertebral in different approaches, having difficult approaches. But Professor Atul Goyal in 2001, he said that most of them can be operated through a posterior suboccipital approach. And he said that we do not need to struggle with different approaches. We can do with a posterior approach. But then one has to look at the meta-analysis and decide which cases actually can be done through the posterior and which cases one needs to do the posterolateral approach. Now, this was a review came in 2023 of the different surgical corridors for foramen magnum tumors. And in this, basically, there are three different approaches. One is midline suboccipital, one is the lateral approaches, and one is the ventral approach or the transversal approach. There are many variations of the posterolateral approach, like occipital transcondylar, supracondylar, you have transjugular process, transtubercular, paracondylar, and some people have done it by preserving the bone also without doing laminectomy or without doing suboscopal craniectomy. They work in between the lamina to preserve the bone and take out the tumor. Unfortunately, the tumors of C1, C2 behave differently than tumors in the cervical spine, because cervical spine has a lateral mass and reaching the posterolateral is difficult. Whereas in C1, C2, because of the ganglion, you have a wide area, there is no lateral mass there. So one can still do many approaches with just posterior approach. As Dr. Abhida was explaining, that if you have a neurofibroma of the C2, it can be done with just a posterior approach by following the plane or the interdural plane. Is the anatomy which helps us to decide whether to do a posterior approach or a posterolateral approach. Now, there are this systemic review in 2021. When they analyzed all the foramen magnum meningiomas starting from 1996 to 2019, many people have used all types of approaches, starting from midline posterior fossa to extreme lateral approach, far lateral, transtubercular, transpetrosal, and it is confusing for a surgeon who starts practicing which is the best approach. We also published our results of the need of condylar resection, and over a period of time we realized that condylar resection is not required, and most of the tumor can be done through a posterior approach, and one has to understand the need of condylar resection depending on the extent and the consistency of the tumor. So how do you decide the best approach for a particular tumor? Now, the best approach can be decided by visualizing the scan. If one does a posterior fossa midline fossa suboscopal craniectomy, if the tumor is seen on the surface, there are different corridors. Like if the tumor is seen either between lateral to the vertebral artery, or if the tumor is seen between the vertebral artery and the medulla, or the tumor is seen above the C2 nerve roots and below the C1 nerve root, or lateral to the spinal accessory. These are the four corridors. If the tumor is seen, all these tumors can be done through a midline posterior fossa. One need not do a extreme lateral or far lateral approach. Now, this can be visualized by studying the radiology properly. Like this patient, this patient has a posteriorly and posterolaterally located. This can be done easily through a posterior approach. Like this, again, the tumor is pointing on the surface. So if one does a posterior fossa craniectomy, though that attachment is ventrally, but the tumor is pushing the cord. Again, this can be done through a posterior approach. Like again, this case, though it is attached ventrally, but the tumor is pointing in the cerebromedullary fissure on the surface. One does suboccipital craniectomy, one can see the tumor surface without any retraction of the brain stem, and these tumors can be done through the posterior approach. But if the tumor cannot be seen on the surface, then one has to have an alternative approach. So to decide what is the best way, we classified the tumors depending on the location, whether it's anterior attachment or lateral or the posterior attachment, and the extent of tumor, whether the tumor is purely interdural or a purely extradural tumor, or the tumor is a combination of extra or interdural combination. I'll give example of each one. Like this patient is a purely anterior tumor intradural. This interdural tumors are not good for a transfer, as it is seen posteriorly. It is better to do a posterior approach. Whereas this tumor, which is purely anterior, which is an extradural tumor, very small interdural extension, and this has to be done through an anterior approach, and we did a high cervical extrapharyngeal approach. Compared to this tumor, which is laterally located, this is purely extradural tumor, and going into the neck, whereas this tumor is a laterally situated tumor, but has both an intradural component and an extradural component. And this needs a different approach. I'll be explaining what is the best approach for this kind of tumors. So if you're posteriorly located, one do a posterior approach. And if it's a combination of intradural and extradural, one can do a posterior approach, do intradural dissection of the tumor and remove the tumor. So midline suboccipital is done for posterior lesion, whereas for combined intra and extradural, one has to do a par lateral approach. For anterior intradural is a par lateral. For anterior extradural, it's a high cervical extrapharyngeal. And when it's a combined intra and extradural, one has to do a combined craniocervical approach. So basically, three types of approaches are required: high cervical extrapharyngeal for anterior extradural, for posterolateral situated is a par lateral, and a combined craniocervical approach when there is a combination of intradural and extradural tumor which is present in the compartment. Like this tumor, the tumor will be seen when you do a midline suboccipital craniectomy. One can see the tumor here, though the attachment is ventrally. It's a good case for midline suboccipital. Again, this case, it will be seen if the tumor is seen on the surface. It's a good case for midline suboccipital. And again, this case, the tumor will be seen in the cerebellum medullary fissure when you do a midline suboccipital, and it's a good case for midline suboccipital. Whereas this case, where there is a neural tissue covering, it cannot be done through a midline suboccipital. One has to do either a par lateral or an extreme lateral to have an excision of tumor. So this patient we do with a lateral position. This is the incision we do. We reflect the whole flap as a single layer, not with three layers, and then do a retrocondylar dissection. The posterior third of the condylon is dissected till the condylar vein is reached. And the dura is reflected laterally. And then the vertebral artery is identified, and the tumor is identified there. This is a spinal accessory, the C1 nerve root. This is the tumor. This is arising from the vertebral artery. The dentate ligament is incised to identify the vertebral artery. And tumor was adherent to the vertebral artery. It was detached using a thulium laser to devascularize the tumor. And tumor was taken out in piecemeal as it was very highly vascular, detaching it from the vertebral artery. After it was detached, then internal decompression was done with the laser. The laser has a small footprint. It's easier to do hemostasis rather than using a bipolar. And then the tumor, the capsule was dissected from the brainstem. Intermittent decompression and dissection was done. And finally, the tumor was removed. So this case cannot be done with a midline posterior fossa. One has to do a par lateral approach. And finally, the dura was closed. So these are the still pictures of the case. But this is whereas this case, which is has both an extradural component and an intradural component. You can see here that the tumor going through the jugular foramen, going outside. or preliminary diagnosis and coming down till the neck through the jugular foramen. Our diagnosis was there was a paraganglioma. Embolization was done with preoperatively, and tumor blast was reduced. And this is how the patient was positioned. And this is how the incision is done when we plan to do a craniocervical approach to expose both the cervical part as well as the intracranial part. We do a posterolateral approach without mobilizing the facial nerves to prevent facial nerve palsy. Like we save the facial nerve in the canal. We work posterolateral to the facial nerve to the transjugular process approach, expose the whole sigmoid sinus, the jugular bulb, and the internal jugular vein, and then deliver the tumor from inside the sigmoid sinus by cutting the sigmoid sinus, and deliver the tumor from the jugular vein by cutting the jugular vein. So this is the part excision from the section of the neck. Mastodectomy is done to skeletonize the whole of sigmoid sinus and the transverse sinus. Then the sigmoid sinus and transverse sinus junction was a temporary clip was placed. And then sigmoid sinus was opened. And the upper pole of the tumor was delivered from the transverse sinus. Then the internal jugular vein was dissected in the neck, again ligated from below. An internal jugular vein was opened up to take out the tumor from the jugular vein. One is to follow the tumor, preserving the wall of the sinus to prevent damage of the lower cranial nerves. If one remains inside the wall of the jugular vein, the chances of damaging the cranial nerves are less. And then the sigmoid sinus and the internal jugular vein are connected by unlocking at the level of jugular bulb. After the extradural part is removed, the dura is opened to take out the interdural part of the tumor from the CP angle. Is it, in spite of embolization, it was vascular, but hemostasis could be achieved by just packing with a fat wrapped with fibrilla. And this is at the end of excision of the tumor. And the gap was filled with fat and closed. So these are the picture steps of surgery. I had done that. The video doesn't open to show the steps of surgery. And this is the post-op scan. Some residual tumor is there and the patient is under follow-up. This is another case of a glomus, again, both intra and extradural component. And this is the post-op scan and without any facial palsy. Whereas tumors like this, which are anterior and anterolateral located, purely extradural, presenting with hypoglossal palsy, one has to do, and a tumor like this, which is extradural, one has to do a high cervical extrapharyngeal approach by L-shaped incision. Exposure is similar to the anterocervical discectomy. The hyoid ligament and the hyoid muscle is divided from the hyoid bone so that the pharynx can be retracted medially to expose the tumor. And this is the tumor which has given yellow fluorescence. One can see the green color. The tumor was excised. This is the fluorescent tumor. And this is at the end of excision of tumor. So the commonly used approaches are for posterior lesions, a midline posterior, midline suboccipital approach. For anterior intradural lesions, one has to do a paralateral approach. For anterior extradural lesions, a high cervical extrapharyngeal approach. And whenever there is a combination of extra and intradural lesions, the lesions going into the neck, a craniocervical approach is helpful. In conclusion, condylar resection is not required in many of the cases. One not be dogmatic that all the cases can be done through a posterior approach. The approach is customized depending on the extent of the attachment, the consistency of the tumor, and whether the tumor can be seen from the posterior approach, and one has to visualize it from the MRI, whether the tumor, any surface of the tumor is seen between the neural structures or through the four corridors I explained. Those cases can be done through the posterior approach. Other cases, one has to do a far lateral or extreme lateral or a high cervical extrapharyngeal approach in tumors of the foramen magnum. Thank you for your attention.
Thank you very much, Dr. Panigrahi. Excellent presentation. And the next speaker is Dr. Sabas Ceylan, and he will talk about endoscopic approaches to cervical craniovertebral junction. Please, Dr. Ceylan.
You must unmute yourself.
It's okay?
Yes. First of all, I would like to thank for this kind invitation, Professor Zileli, dear chair, and their colleagues. I'm going to talk about endoscopic endonasal transsphenoidal approach to craniocervical junction. Sorry. Endoscopic transsphenoidal approach has been performed first time by Jankowski.
Sorry, dear Savaş, there is a problem with the magnification of your images.
Sorry. I'm trying again.
They seems like they are more magnified.
Okay.
Now it is good. Thank you.
Okay. Endoscopic transsphenoidal approach has been performed first time by Jankowski, but the detail of this approach has been described in detail by Joe et al. This established technique have been used by many authorities from different countries. Endoscopic transsphenoidal approach include two approaches, standard and expanded approaches. These extended endoscopic approach have been used to reach from lamina criprosa to craniocervical junction. All midline skull base lesion can be used extended endoscopic approach. And the lower clivus include craniocervical junction. These anatomical landmarks, lower clivus and the odontoid tip, anterior arc of C1, craniocervical muscles, and buccopharyngeal fascia. Sorry. Transcranial and endoscopic approaches, the clivus is divided into three parts. These are superior clivus, middle clivus, and the inferior clivus. Inferior clivus contain lower clivus and craniocervical junction. For this region, we routinely use transclival and transodontoid approach. Median and the paramedian lesions are very suitable for extended endoscopic approach. All pathologies involving clivus and craniovertebral junction, these are malign neoplasm, most common chordomas, chondrosarcomas, pituitary adenomas, petroclival meningiomas, and the other non-tumoral lesions. Endoscopic approach has been performing in 6,000 cases in our clinics since 1997. The most common pathologies, chordomas. Chordomas are tumors develop from extraaxial and the notochord residues. These tumors grow slowly, but aggressive tumors. Because of similar presentation of radiological appearance, chondrosarcomas are discussed together with chordomas. We reported our experience with 72 cases with chordomas and chondrosarcomas 3 years ago. Of these, 9 cases located inferior clivus and craniocervical junction. In the series, our gross total resection rate 75%. Essentials of surgical treatment. Surgery is the most effective treatment option. The volume of residual disease has a major effect on disease course. Initial treatment attempt has the highest chance of success. High dose radiation therapy should be considered in all cases. The surgery should be performed at centers of excellence. The operative nuances in the surgery, these are tumor relationship, very important. The other nuances, tumor extension and localization, and the tumor adherence and consistency, and the recurrence. In this report, we describe anatomical limitations, extradural and the intradural. Extradural limitations for lower clivus, bilateral occipital condyle laterally, and the C1, C2 inferiorly limitations. Our first case, 10 years old girl patient, this tumor extended choana, tumor involved choana. Firstly, we performed internal decompression. After internal decompression, and the tumor capsule was dissected from surrounding structures, and then we reach lower clivus. You see lower clivus. This tumor destricted lower clivus, but we remove lower clivus to access superior extending tumor, and then we reach a lower clival tumor. Firstly, this tumor was resected with ultrasonic aspirator and the other instruments. In this case, we explore and we reach inferior part of tumor. And in this region, we explore occipital condyle and atlanto-occipital joint. You see, atlanto-occipital joint and occipital condyle. And now lateral extending tumor was removed. And then in the last period, we reach retro-odontoid area, and tumor capsule was open. In this region, in this retro-odontoid region, we went as deep as we could. We reach the deepest point of tumor, and this retro-odontoid tumor was removed. And the other case, in this case, we performed stage surgery. In the first surgery, we removed lower clival tumor, and the second surgery, we performed transodontoid approach, and we reach C1 arc, and the lateral left side C1 anterior arc was removed, and then we reach condyle. In this case, we performed medial condylectomy to reach a lateral extending tumor, and we explore now. We removed medial condyle, and then we explore lateral extending tumor, and this tumor was removed. The other case, this case, very interesting case, 3 years old boy, tumor involved craniocervical junction, and we reach C1, you can C1, and odontoid tips, and the tumor was dissected from tectorial membranes, and this tumor is removed near totally. Pathological diagnosis, the differentiated chordomas. In the other case, this huge tumor, extradural tumor, extends odontoid tip and craniocervical junction. This extradural tumor was resected totally. We reach craniocervical junction, and we explore anterior arc of C1, and then lateral condyle was explored. And this case, the inferior point, we control vertebral arteries with Doppler, and this tumor is removed totally. In this case, we try to access extradurally hypoglossal canal. The other case, this case is one of the last cases. This firm tumor, very hard tumor, we perform transodontoid approach. We explore tumor capsule, and capsule is opened, and then a tumor was removed intracapsularly. For intradural tumor, limitations for lower clivus, hypoglossal canal, and foramen jugulare laterally, and the medulla and the medulla oblongata inferiorly. In this tumor consistency is important for resection. The first case, huge tumor, extends odontoid tip and craniocervical junction. Firstly, extradural tumor was removed, and then infested bone and tumor is removed from intradural region and the basilar artery and the pons and 60 nerves. And in this case, we reach lower cranial nerves. The other case, this one of the most difficult cases in our series, huge intradural tumor. Firstly, we explore clival dura, and then clival dura opened vertically, and then we explore tumor. This adherent tumor, firstly dissected from right side pons and medulla, and this tumor dissected and resected, and we explore lower medulla, and you see lower cranial nerves. In this case, after tumor resection, and you see basilar arteries and the pons and medulla. In this case, we reach lower cranial nerves, you see, and then we access hypoglossal canal in this case. The other intradural tumor, this tumor involves craniocervical junction. We reach craniocervical region, and firstly, extradural tumor was resected. We used ultrasonic aspirator. And then this is interesting case. We explore clival dura. There are many dural defects. We removed intradural tumor through these dural defects, and we continue tumoral resection. We removed all pieces of intradural tumor components, and at last stage, last piece of tumor was removed, and then we reach pons and medulla. We explore pons, and the medulla, we explore lower cranial nerves. The other pathologies, craniopharyngiomas, this case was operated 4 times previously. We operated last type, and this tumor is removed totally. This tumor extends craniocervical junction and odontoid tip. This tumor was resected totally. The other pathologies, complex meningiomas, is very difficult cases. This tumor extend cavernous sinus, sphenoid sinus, prepontine area. In this case, firstly, sphenoid tumor was resected, and we open cavernous sinus. You see anterior wall of cavernous sinus. We enter lateral compartment of cavernous sinus, but very firm tumor. We resected with ultrasonic aspirator. Total resection was performed. The other complex tumor, this case is one of the last cases. Tumor extent sphenoid sinus, cavernous sinus, and craniocervical junction and odontoid tube inferiorly. Firstly, sphenoid sinus involved tumor was resected. At this stage, we perform extradural dissection and resection, and this tumor was resected. And then the second stage, in this case, we open cavernous sinus. You see, cavernous sinus anterior wall was open, and we continue Doppler, and we enter lateral compartment. A very firm tumor was resected with ultrasonic aspirator. At this stage, we routinely used Doppler, and the tumor was removed from between horizontal paraclavial and petrosal segment of carotid arteries. And the last stage, we reach craniocervical junction, and extending tumor pieces was removed. The other pathologies, giant cell tumor. These tumors are very interesting tumor. This tumor, very hemorrhagic tumor. You can encounter massive hemorrhage and bleeding. In this case, therefore, we stop first operation. This patient was embolized. After embolizing, this patient was operated again, and this tumor removed totally. The other pathologies, pituitary adenomas, some huge giant adenomas extend a craniocervical junction and odontoid tip. This tumor extend lower clivus, and also it extend prepontine area, retroclival area, and this tumor was removed near totally. Recurrent cases, endoscopic approach can be used very easily. This case and the second surgery, lower clivus involved tumor was removed totally with extended endoscopic approach. In the last case, basilar impression and the other congenital pathologies, you can prefer transodontoid approach. Endoscopic transodontoid approach, very easy approach. We used routinely vertical incision, and we opened buccopharyngeal fascia, and then we dissected craniocervical muscles, and we reach C1, and we drilled C1 arc, and we explore odontoid tip. In this case, we removed only odontoid tip and odontoid bases preserve, and you see after removal odontoid tip, we explore transverse and the other ligaments. In these cases, endoscopic technique is more confident and effective in midline and craniocervical junction lesions. Combined approach should be preferred when necessary. Gross total resection is main purpose. Surgery should be performed in experienced multidisciplinary centers. Thank you for your attention.
Thank you very much, Dr. Ceylan. Excellent lecture and beautiful cases. And I will be the last speaker. So I am going to talk about foramen magnum meningiomas, that something was talking before. And the region of the foramen magnum is above and below the foramen magnum, some millimeters above, some millimeters below. And of course, the anatomy of this region is so important to recognize the B3 and B4 portion of the vertebral artery, the spinal accessory nerve, the denticulate ligament, the medulla, and also the spinal cord, and the branches of the B4 portion of the vertebral artery, and so on. So in the foramen magnum region, we can see lesions extradural, intradural, extraaxial, and intraaxial, like cavernoma, meningioma, and chondrosarcoma, for example. But in this lecture, I'm going to talk about intradural, extraaxial lesion, the meningiomas, and also the meningioma of the foramen magnum. The attachment of the meningioma could be anterior, lateral, or posterior. And sometimes, or usually, we have anterolateral attachment of that kind of meningiomas. I'm going to talk about anterior and lateral foramen magnum meningiomas. Another important thing is that sometimes the meningioma start below and grow up. So usually the lower cranial nerves are above the tumor, so it is a little bit more easier to remove that kind of tumor. But sometimes we have craniospinal meningioma, so start above and then grow to the inferior portion, and usually the lower cranial nerves are in the posterior portion of the tumor. If we read the literature, there are many kinds of far lateral approaches. But in this kind of, we have to try to simplify the things. So in this kind of tumor that usually we perform a far lateral approach, we divide in two kinds, the retrocondylar approach or transcondylar approach. So in the retrocondylar approach, we open the foramen magnum in that side. Also, we cut the posterior arch of C1, but we don't touch and we don't drill the condyle. And in the transcondylar approach, we also drill a little bit the condyle in order to have a better view of the anterior portion of the foramen magnum. So we can see in this picture, anatomical picture, the view of a retrocondylar approach and of the transcondylar approach, where we can go better to the anterior portion of the foramen magnum. But another important thing, anatomical thing, is usually we try to expose the V3 segment of the vertebral artery. And we saw in many courses, anatomical courses with cadaveric specimens, that it is, especially for the young people, to know how to expose in a good way the V3 segment of the vertebral artery. So we studied the attachment of the posterior muscles of the cervical spine, and we know that we have four limbs. The first is the trapezius and sternocleidos. The second is the splenius. The third is the semispinalis, and the three first layers of muscles attached in the upper portion in the superior nuchal line. And the deepest layer of muscle, that is rectus minor, rectus major, inferior oblique, and superior oblique. The rectus minor, the rectus major, and the superior oblique, the attachment is in the inferior nuchal line. And of course, we have here the occipital triangle with the B3 segment of the vertebral artery. So we published in some years ago this paper that you can read in Neurosurgery about the utility of the nuchal lines as an anatomical landmark to dissect and to find the V3 segment of the vertebral artery. So it is very important, especially for the young people, to go to the laboratory to learn the three-dimensional anatomy of all the regions in the skull base and in the brain, and also in order to have better surgical praxis. And this is our idea, is from the laboratory to the operating room, because this is the real power of the anatomy. So using the nuchal lines in order to find in a good way the vertebral artery, we perform that kind of incision. We dissect subperiosteal until the first stop, that is the superior nuchal line. So we dissect the three first layers of muscle with the skin and so on, and we continue dissecting subperiosteal. This is the superior nuchal line, and the second stop is the inferior nuchal line. So in that part of the surgery, of the approach, we have to keep the deepest muscle of the nuke in the skull base. So we can see here the rectus minor, rectus major, inferior oblique, superior oblique, and the B3 segment of the vertebral artery. So we use the nuchal lines for perform that things. And this is a video of a real surgery. The last part of that of the approach is to remove the muscles, because we know now where is the vertebral artery. We can see, so we can expose the vertebral artery in a good way. After that, we expose also the posterior arch of C1. This is the vertebral artery, and so on. And then usually we perform a craniotomy like this. We don't have to go too high, because usually the tumor is here, and also we remove the posterior arch of C1 in the side of the tumor. Then expose the dura, and usually we open the dura in this fascia. And we operate all the cases in the semi-sitting position. It is very important that the legs of the patient is above the level of the heart in order to avoid the air embolism. And we operate in this fashion. We use an arm rest in order to work comfortably. I would like to show with some cases. First case, we can see that this lateral attachment of foramen magnum meningioma. So in this case, we used far lateral retrocondylar approach. We don't drill the condyle, just the retrocondylar fossa. So we use this incision and this position. We can see now B3 segment of the vertebral artery, the posterior arch of C1. We are drilling now just the retrocondylar fossa. We don't touch the condyle, because in this case we think it is not necessary. And now we expose the tumor. This is spinal accessory nerve. We are cutting now the denticulate ligament in order to mobilize better the tumor. We use the ultrasonic aspiration in order to remove volume of the tumor. And now we are coagulating and cutting the attachment of the tumor. This is the B4 portion of the vertebral artery, C1, and cutting the attachment. And finally, we remove the tumor. In the semi-sitting position, we usually have a very clean operative field. And the final view with the vertebral artery, C1, the spinal accessory nerve, and so on. And we can see the pre and post-op MRI in the different sequence and cut. and also the patient after the surgery. Another case, a case with an attachment in the anterior lateral portion of the foramen magnum with a big deformation of the medulla and the spinal cord. So in this case, we decided to perform a transcondylar approach. So this is the surgery. Also, this video you can see in 3D. It was published in 2019. Now, in this part of the surgery, right side, semi-sitting position, we are drilling the condyle in order to this mountain of bone to put flat. Now we are exposing the tumor. We are using the ultrasonic aspiration. This is the pica. So we are working below the pica. Here, this is the vertebral artery. Now using the arachnoid dissection. It is very important, like in the posterior fossa tumors. Now we are cutting the part of the tumor in relation with its attachment. It is very important to start from below and go from below to up. And this is the final view: vertebral artery, pica, medulla, spinal cord, and the attachment of the tumor. And we can see the pre and post-op MRI, the sagittal view, axial view, and also the patient in the hospital after the surgery. Another case, a more difficult case with a little bit up direction with a big dislocation of the medulla. This is the craniospinal meningioma. We also use a transcondylar approach. Now we are drilling the condyle. It is very important to coagulate the posterior condyle vein, not to drill because we can have some problems. This is the exposition of the dura. Now we are cutting and open the arachnoid of the cisterna magna, and we are going from below to up. We can see the tumor, some nerves, the pica. So first, we cannot go at the beginning in a big tumor to the attachment in order to coagulate and cut. So we have to debulk the tumor, and then now we are working in the attachment at the level of the attachment of the tumor. We are coagulating and cutting the attachment of the tumor. Also, you can see this video in this journal. So now the tumor is free because we also coagulate and cut the attachment. So now we just perform a debulking of the tumor, and then the arachnoid dissection. We have to take care of all the nerves and arteries. We have to preserve and to rotate the tumor in order to perform a resection of the tumor. This is the final view with the preservation of the medulla, spinal cord, the arteries, the nerves, and so on. And we can see the pre and post-op MRI in the axial view and also in the sagittal view, and the patient after the surgery with the normal life. And the last case that I would like to share with you, a young lady with this tumor with a high and a big dislocation of the medulla and the upper portion of the spinal cord in the coronal view, and also we can see in the axial view with a very wide attachment in the anterior portion of the foramen magnum, the vertebral artery, one and the other, and also in the T2 we can see in the right and left vertebral artery. We also use the semi-sitting position and this kind of incision in order to use the technique of the nuchal lines to find the B3 segment of the vertebral artery. And now we are drilling the condyle in order to flat that portion of the skull base in order to have a better view with the tumor. It is very important to perform the extradural part of the surgery. And now, after cutting the dura, we can see the arachnoid and the pica and the tumor in front of the nerve and so on. So this is the vertebral artery, the before portion of the vertebral artery, C1, and we start with all the windows that we can use. Of course, it depends the case. This is the hypoglossal nerve. We have to perform the debulking and also to dissect the tumor, the external superficial of the tumor from the nerves and so on. But the problem is this case has a very wide attachment, so it is very difficult at the beginning, at least at the beginning of the surgery, to mobilize the tumor and to rotate the tumor. So we have to go with the ultrasonic aspiration to debulk the tumor as much as possible. Now we are working lateral to the vertebral artery, but also we have a lot of tumor between the vertebral artery and the medulla. So now we are working in the window between before and the medulla, also with the ultrasonic aspiration. And now we are working but below C1. So we use all the windows that we can see with the case. Now we are coagulating and cutting the attachment, but we cannot go to the other side of the foramen magnum. So we go again to the tumor to try to debulk and to cut in order to can mobilize a little bit for to coagulate and cut all the attachment of the tumor. But with the drill of the condyle is good in order to have a good vision of the anterior portion of foramen magnum. Now we are cutting the last portion of the attachment of the tumor because we performed a debulking before. This is the view of the foramen magnum, but in the other side, in the right side, we are working from the left side, but this is the foramen magnum in the right side. But we can see now because we don't have too much tumor here. So now the tumor is free. We just have to perform the arachnoid dissection and avoiding to lesion any nerve of or artery or branches. So we perform the arachnoid dissection like in other tumors in the skull base. And this is the vertebral artery of the right side. And we are rotating the tumor in order to remove the last portion of the meningioma. And this is the final view. Removing the last portion, we can see hypoglossal nerve, spinal accessory nerve, vertebral artery in the left side and also in the right side, C1, and so on. And we can see the pre-op and post-op MRI in the sagittal view, also in the axial view, and in the T2 with the reaccommodation of the anatomy. And this is the patient after the surgery. And we can see the windows in order to remove this kind of tumors. In conclusion, the semi-sitting position is an excellent choice in this kind of tumor. According to the location of the type of the tumor, we use retrocondylar or transcondylar. This is our philosophy. And according with the origin of the tumor, the attachment is the difficulty. So when start above, it is a little bit difficult than when start from below. Thank you so much.
Great talks, really. Can I ask all speakers about the concerns about the instability? If you do you have concerns if you remove all the condyle that you'll cause any instability?
In our case, I mean, in relation with the foramen magnum meningioma, so intradural lesion, we never had a patient with that need an stabilization, because usually we drill the condyle just in order to avoid this mountain of bone to put flat. But we don't have any case of instability in foramen magnum meningioma. In extradural tumor, it's different. For example, chondrosarcoma or chordoma, something like that, where sometimes you have to drill much more condyle in order to remove the tumor, or sometimes the tumor destroy part of the articulation.
In our cases, we performed one patient medial condylectomy. In the other cases, we didn't remove condyle in our chordomas and chondrosarcomas cases. In these cases, we don't need posterior fusion. But if we need combined approach, the tumor extent laterally and far laterally, in these cases, posterior approach and posterior fusion is needed, particularly chordomas, chondrosarcomas cases.
We are using the posterior midline approach, in which there is no condylar resection. So we don't need fixation for that. Only in a couple of patients with chordoma, which had an anterior extension, which was involving the condyle and the facets of C1. In that, I think on one side we had done a fixation, and the other side we had removed the tumor. But generally for other meningiomas and such tumors, we are not performing any fixation.
What about vertebral artery management? Actually, especially in chordomas of the region, the artery may be encased inside the tumor. Are you having difficulties in managing the artery intactness?
Intradural lesions, if the tumor located intradurally, in these cases, vertebral artery dissection is easy. If the tumor non-adherent, this tumor can be adherent or non-adherent. Adherent tumor, vertebral artery encasement management is very difficult. But non-adherent tumors, vertebral artery dissection and preservation is very easy. I think tumor consistency is very important for intradural chordomas. But posterior located, I don't have any experience.
Thank you. All talks were very excellent. I thank all the speakers. It was a very nice panel.
Thanks a lot. Thanks everybody.
Thank you very much, Dr. Sileli, and congratulations for your work in education committee. Thank you very much.
Thanks.
We thank you all. I think it's time to finish this panel. Do you want to say something at the end, Alvaro?
No, nothing. Thank you very much, everybody, and good day. Good Saturday and Sunday.
Good night.
Good night, everybody.
Good
Thank
night,
you,
everybody.
everyone. Bye.
Thank you. Thanks.